the roadmap What is medical tourism? Actually, medical tourism started long centuries back in the world because many people, many citizens was traveling from his home country to the other countries, are looking for the best, higher standard and quality of healthcare treatment for themselves in order to be treated in a best quality with affordable prices. Today's, there is so many advanced countries like Turkey are receiving from many other countries where they are looking, their citizens are looking for treatment in different segmentation of healthcare to be affordable, high quality, high standard, and to be used high technology in order that they can return to their home country with their healthy situation. So for medical tourism, we name it who are looking from their home country to travel abroad, to travel to another country, to get the treatment and to be treated high quality, high standards, and affordable prices. Ladies and gentlemen, dear colleagues, dear partners, I would like to draw you the roadmap of our collaboration in between you and us. As a step one, you have several choice of cooperation. Turkish Healthcare Travel Council has a local representative offices in your region, which they do speak your native language, and they are ready to serve 7 to 24. That in order to help you, to assist you, and to communicate and to facilitate between you and our clinics and hospitals and local partners. As well as you can have the option that you can choose one of travel agent medical tourism facilitator from our participant, and you can build a cooperation and partnership, and you can refer your patient through them as well. And also as third options, you can choose and work directly with the clinics, international patient departments. That is totally up to you to choose one of this way of cooperation in order to refer your patient to Turkey and to follow up with your partner or with our offices locally based, and they are ready to collaborate. As a step one, you need to choose your partner with whom and which way that you would like to refer your patient. As soon as you share all the medical reports, MRI and all other medical information of your patient, your chosen partner will send to related hospitals all this information and will collect treatment plan and approximate cost and price for your patient who are going to be treated in Turkey. And they will come back to you with treatment plan and with cost. And after, you will negotiate with your patient, and if they agree to travel to Turkey, then your partner can arrange the appointment in a related hospital, which you agreed, that you can send your patient to start their treatment. Also, there is an option before they travel. If there is no clear medical reports and medical information about your patient, possibly we can arrange, or your partner, chosen partner, can arrange an online consultation between related doctors and your patient that in order they can understand what exactly and which kind of treatment need to apply for your patient. This option always available in our member of hospitals and participant in our exhibition. Of course, after referring the patient, your local partner or your chosen partner, either Turkish Healthcare Travel Council representative offices, either travel agencies, medical tourism agents, or the hospitals, will arrange your patient arrival transfers, accommodations, booking nearby hospital, and will follow up during the treatment, and they will help and assist your patient in order to feel comfortable during the treatment period. Also, as Turkish Healthcare Travel Council, we have appointed medical directors working closely with our representative offices, and they are following all our referred patients through the THTC, Turkish Healthcare Travel Council offices. They are following locally in the same city the treatment process, and they be always in touch with the patient and the companions and with family to give them more comfort and more way of feeling at home, and to be followed up by our medical directors to make their life easier and treatment easier. Within this cooperation, after the treatment completed, of course, according to your partner agreement, either with our offices, representative offices, or with your new partner travel agent or the clinics, you may have kind of an agreement of follow-up fee for your referred patient, that in order the post-operation that you can able to follow up and keep contact with your patient, and also to be sure that your referred patient happy and return back home with treated and come back to their health. All your partner, including our offices, travel agencies, medical tourism agents, and the clinics, of course, they are ready to award your work with success of treatment and also with follow-up fee, that in order to cover your valuable time which you spare during this period. So we are always welcoming all our partners to collaborate with us in this roadmap. And also, as I mentioned, that possibly you can collaborate with other options of medical tourism agent or directly with the hospital and clinics. This is totally up to your choice, whether you will cooperate in your country with our offices, or internationally you can collaborate with our medical tourism agent and the clinics. This is our roadmap of cooperation, and you can able to follow up this procedure, and you can build cooperation in between our exhibitors and yourself. Thank you very much once again joining our event.
Hello, I am the professor of otolaryngology department of Istanbul Medical University, Dr. Mohammed Fatih Erçin. Today I'm going to make a presentation on the indication for the installation of cochlear implants. But before that, I would like to briefly discuss the subject of hearing loss. It is currently believed to be a serious health condition because out of 1,000 of the newborn, we observe 1 to 3 children with hearing loss. Also, there is age-related hearing loss, and about every third person who is over 60 years of age has this problem of hearing loss. Also, we can observe it in some health conditions, even in younger age, such as meningitis, chronic otitis, or cholesteatoma. And generally, we attempt to tackle the issue of hearing loss by using the traditional hearing aids. Unfortunately, in some cases, they do not solve the problem, and in such situations, a cochlear implant would be necessary. But why is it so important to solve the hearing problem? Well, when studying the hearing loss, researchers also noted that it is connected with the loss of communication abilities and memory. People are getting their signals from 2 main sources, from their eyesight and hearing, and this becomes increasingly important in the older age. If the person does not hear well, they limit their contacts with the outside world. They are afraid of being misheard, they are afraid of giving the wrong answer, and by closing down, they create conditions for the development of dementia or the Alzheimer's disease. Therefore, it is very important to hear even in the older age, because for the brain to work, it needs to get signals. Such signals are usually obtained through hearing and seeing. So how does a person hear? As we know, the hearing system consists of the outside ear, the middle ear, and the inner ear. Actually, the outer ear and middle ear are not that important in the process of hearing, much less important than the inner ear, which is mostly responsible for hearing. And inside there is a so-called acoustic labyrinth with hair cells which receive the sound and transfer it to the brain through the 8th pair of nerves. Some part of those hair cells are suitable for high-pitched sounds and some of them for low-pitched sound. And if those hair cells do not work, unfortunately, no sound goes through the hearing nerve. The deterioration of such hair cells can be due to some hereditary disease or because of some disease at a later age, such as maybe meningitis. Also, there is some age-related loss. A person first loses ability to hear high-pitched sounds and then other sounds as well. Hearing loss can be classified into 3 types. Conductive, associated with the possibility to conduct sound. Also, the neural type of hearing loss and the mixed type. The conductive hearing loss usually has to do with the problems with tympanus and also the tissues of the middle ear. And also there are sensorineural type hearing loss, which has to do with the hair cells and also with the 8th hearing nerve. So the problem we are considering now is the sensorineural hearing loss. The usual treatment that we recommend is the correction of the tympanus or the operation on the mid-ear if they are able to solve the issue. However, if there are some sensorineural problems as well, we recommend to use the classic hearing aids, which can be effective in cases of simple hearing loss. But if this hearing loss is at a more advanced stage, unfortunately, those hearing aids would be not effective. And there are some more effective methods, the implants of the mid-ear, the so-called BACA devices, we also use them. But also recently we see quite a dynamic development of cochlear implants, and in the long term they make a lot of benefit for the patient. A cochlear implant is an electronic device which implements the functionality of the labyrinth in case it doesn't work. The implant consists of the outer and inner parts, which are connected by means of magnet. The sound that is obtained from the outside with the use of a microphone is transferred through the electrode and then through the hearing nerve to the central nervous system. And is this method reliable? Well, actually, when it was developed, a number of problems existed, but thanks to the development of the technologies, those problems were solved, and right now this operation is not much different from any traditional operation, such as, for instance, a dental implant. And historically, the development of such implants started in the 18th age, and in the 18th century, people started from sending electric impulses to the ear. Later, when people learned to get a response from that tool, the development continued, and in 1984, the United States Food and Drug Administration approved its first implant for the adults, and later in the 1990 the first implant for the children of 2 years of age, and later in the year 2000 for the children of 12 years of age. And this is exactly the age at which children are suitable for implants in Turkey. We have two major companies, Medal and Cochlear. There are some other companies as well, AB and Oticom, but the first two ones are the most active and made a huge contribution to the development of the implants. So right now there is a huge progress in this field, even some robotic operations. So we are using the implants of two of those companies. The companies are Medal and Cochlear. So I will briefly explain about the inner part of the implant. Inside there are two important elements. One is the electrode, which is introduced to the labyrinth, and the second part, which is the receiver, is implanted under the skin. And if the patient has hearing loss at the advanced stage, we use some surgery to introduce the electrode, and the receiver is connected to the outer part with the help of a magnet, and the microphone collects the sound and transfer it to the inside part by means of electric signals. The inner parts can be different depending on the manufacturer, but generally they have this magnet part with the sound processor and the electrode part. And the electrode part may be slightly different depending on the patient's need. If the patient has not sufficiently developed labyrinth, we can use a short electrode. Also, for a child with some special anatomic features, we can select electrodes with specific features. So how does an implant work? The outer parts with the wire are almost not used anymore. Right now we are mostly using a more compact outside part, and only a small part of it is visible under the hair, and it is connected with the magnet on the inner part. So such devices are using in the recent time, and we see increasing use of such devices. Also, the majority of companies enable rechargeable batteries in such devices. So the sound is connected by the microphone and transferred by means of the electrode to the hearing nerve. There are some contraindications, especially in case of hereditary hearing loss, with hearing loss over 80 decibels on both sides. Some scanning then is required, scanning of the hearing system, and we run such scannings for almost all children within the first 6 months of their life. We try to discover hearing loss on this early stage, and if we are noticing such hearing loss, we also perform some additional checks using the BERA and ABR methods. And if this hearing loss is confirmed, then we install a hearing aid to a child up to 1 year of age. By means of this hearing aid, we try to stimulate the development of the brain area responsible for hearing, and even if it's imperfect sound, it doesn't matter, it can be just noise, it's already good. But when the child achieves 1 year of age, we need to install a cochlear implant, because otherwise this area of the cortex will be used for other purposes, such as vision. So the earlier we are able to install the cochlear implant, the better. Right now, there is an age limitation in our country. The minimal age for cochlear implants is 1 year of age. But if we install the implant at a later stage, such as 4 or 5 years of age, the child will benefit much less, because they will lose this important period of neuroplasticity. Of course, they will also get some benefit, but they will not achieve the same level of speech as the children who had the implants installed at 1 year of age. But what if a child has the hearing loss of 70 decibel in one ear and 90 decibel in another ear? Will the implant be installed? Yes, we install implants to children with hearing loss of 90 decibel in one ear and 70 decibel in another. And in our country, we are right now using the installation of implants on both ears simultaneously. If there are certain problems with the anesthesia, we are install the implants one by one, but usually they are installed simultaneously. So the implant is installed if there is a development of hearing loss, and if it is over 80 decibel, and the patient has no speech impediments, but has some articulation impediments, but still the patient can read the lips. So the patient is suitable for a cochlear implant. But if the patient was not introduced to the implants earlier, and there is no development in the post-operation period, then even the best cochlear implant will not provide any results. So for adults, we say that there should be at least some minimal hearing in the person, and the person needs to be able to speak, at least to make some short sentences and to read lips. But we expect to get some response to sound stimulation. In case we do not get any response, unfortunately, such a patient will not benefit from an implant. And when can we say that cochlear implants are needed urgently? Well, here I would like to point out meningitis. If meningitis entails hearing loss, the person needs to get a hearing implant very quickly, because otherwise, if the person develops cochlear otosclerosis, unfortunately, in such a case, the cochlear implant will not help, and we will need to install a brainstem implant. So in case of meningitis and meningitis-related hearing loss, when we observe the implants on the inner ear, we need to install the cochlear implant as fast as possible, because if there is atosclerosis, the quality of tissues in the place of installation of the electrodes deteriorates, and we will not be able to accomplish a positive result later. So this is influenced by the condition which is caused by inner otitis, and there are some techniques which are used on the inner ear, but unfortunately even this is not sufficiently successful. So there is a use in installing implants earlier. Also, there is another indication of toxicity when the hearing cells are damaged by some medicines, and we are then trying to restore hearing by means of a hearing aid or a cochlear implant. If it is a developed stage of hearing loss, we see that there will be no use of using a hearing aid, and we recommend a cochlear implant. There is one more thing to know. If the ear has been injured and the liquids in the ear have been mixed, the cells do not work anymore, a cochlear implant can be recommended if the labyrinth is still intact. If a child did not have hearing problems in early childhood, but then because of jaundice or other diseases had their hearing harmed, but then such methods as BERA and IBR need to be used to test the hearing system, and if the hearing loss is considerable, the cochlear implants need to be installed. Also, there is a different problem, which is hearing neuropathia, and sometimes the issue is a more complicated one. It's about the internal conductivity of the neurons. So in this case, we need to provide a more in-depth observation of the patient. So if the signal is obtained from the inner ear, we can say that the inner ear is functional. But if there is a problem in the connection between the inner ear and the neuron, then the patient has hearing neuropathia. And we recommend such patients to use a hearing aid for some time, and if the patient does not get any benefit from it, usually we recommend a cochlear implant, and usually the patient benefits much more. Meniere's disease is the disease of inner ear, which is accompanied by vertigo and hearing loss. Unfortunately, in such patients, the loss of hearing progresses and becomes permanent. The patient is not getting any benefit from a hearing aid, and so in such cases we recommend cochlear implants, and we are noticing that the patients get the reduction of tinnitus in such cases. Also, patients with presbyacusis are the most often operated on type of patients after children with conductive hearing problems. Usually, such patients say that they hear people talking to them, they hear the sound, but they cannot understand what exactly is being said. So they have problems with processing the sound, and in such cases cochlear implants are quite effective. The patients who were using hearing aids before and then installed the cochlear implant, they are noticing much better benefits from the implant, and also we are noticing the improvement of their speech. Quite often patients believe that cochlear implants are only installed in children, but actually that's not true. Anyone from age 7 to 77 can have a cochlear implant installed, and that's not a complicated operation. It takes about 2 hours to install and an implant and the post-operative period is not very problematic. It takes a couple of days for the patient to come back to their normal life. It takes about 1 week for the ear to recover, and we install the outer part on the 15th day. In the first 6 months there are some distortions of sound, but over time the brain learns to code the sound received from the implant, and the quality improves. Right now there are many developments about the built-in electrodes, and quite recently perimodal electrodes became more popular because they are closer to the nerve endings and they do not spread unnecessary signals around them. They are slightly more expensive, but perimodal electrodes produce better results with speech and articulation. There are some counter-indications for cochlear implants. If there is some problem with the cochlear nerve, or if there is no cochlear nerve, if it was cut surgically when operating on some tumor, and this unfortunately is a contraindication. In such case, we recommend a brainstem implant. In our center, the brainstem implants are also available. There are also some conditional contraindications such as the chronic otitis. If in the postlingual period there is no development of speech and hearing, such patients will not benefit even from the best implants. That's the end of my presentation. Thank you very much for your attention, and once again I would like to emphasize that cochlear implants are the treatments used around the world. The contraindications are very limited right now, and we are observing wonderful results in the patients, and we can see that healthcare is moving forward very fast, because cochlear implants is the only type of operation that can in essence substitute the ear. And if the cochlear implant is installed on time, the patients hear well and can speak just as any one of us. And we can see that if the cochlear implants were installed in early childhood, we can see that over time it becomes impossible to notice from the person's hearing and speech the fact that they are using an implant, because they have perfect hearing and articulation.
Hello. First, I want to introduce you myself. I am Dr. Nale from Cologne Hospital. I'm an associated professor on OBGYN, and also I'm an IVF specialist. I also study stem cell therapies, and I have been in the United States for stem cell applications. Okay, first, I want to give some information about infertility and infertility problems. First, I will start with defining infertility. What is infertility? How do we say to a couple if they are fertile or infertile? The inability to become pregnant after 1 year of intercourse without contraceptive methods, we think that this couple is infertile. But if the woman's age is above 35, we have to define infertility term after 6 months. Because as we all know, ovarian age is going on. There are many causes of infertility that needs to be treated. IVF is one of the treatment methods of infertility, which has a greater impact on pregnancy and live birth rates compared to other treatment options. And our center, the IVF Center, offers the most effective fertility solutions for couples with ultimate techniques and long-time experience. In this method, IVF, a complex series of procedures are used to help with fertility or prevent genetic problems. Why should I need an IVF treatment? If you have absent or blocked fallopian tubes, in this case, your oocytes and sperms cannot come together and you cannot get pregnant. If you have severe male factor infertility, if you have low sperm count, if you have low sperm motility, or if you have no sperm, you need to have IVF treatment. If you are advanced reproductive age, the time to conception is critical and pregnancy rates with other therapies are unfortunately low. If you have endometriosis, this means you could have ovulation problems and if you could have low egg number. If you have ovulation disorders and you cannot get enough answer from other treatments, IVF could be a good option for you. In 1/3 of the cases, we cannot find any common cause that needs to be treated. That's why we call these couples unexplained infertility. Also, in these cases, IVF treatment results are higher than other treatment options. And also, if treatment with other therapies are not effective, are not enough for you to get pregnant, you should try IVF treatment. And also, if you are not infertile, but you have an inherited genetic disease that you wish to avoid passing on to your child. In this case, IVF is combined with other laboratory techniques, pre-implantation, genetic diagnostic tests, and then you can have a child without the disease. This means that the embryos, we test the embryos for the disease, and only those without the disease are transferred to the uterus. If you have premature ovarian insufficiency, in case less eggs are available, you should need IVF treatment for best results. If also you need fertility preservation for cancer or other health conditions, if you're about to start cancer treatments such as radiation or chemo, that could harm your fertility, and IVF for fertility preservation is your only option maybe. Women can have eggs harvested from their ovaries and freeze them in an unfertilized state for later use, or the eggs can be fertilized and frozen as embryos for future use after the treatment. Let's see what steps you are waiting during IVF treatment. The IVF procedure consists of several steps that take place over a period of weeks. Stimulation of the ovaries to produce several ovarian follicles, each of which contains an egg during ovarian stimulation. Normally, if you don't have any treatment, you can have only 1 egg per month. But with IVF treatment, we increase the number of eggs that we can collect during this treatment to increase our chance for pregnancy. And after ovarian stimulation, we will retrieve your eggs from the ovaries and obtaining a semen sample, and fertilization of the eggs with sperm and growth of the embryos in the laboratory, and transfer 1 or more embryos to the uterus after that. First, let's talk about ovarian stimulation. The first step of the IVF procedure generally involves the use of fertility medications to increase the number of eggs follicles that develop in the ovaries and control the time of ovulation. The stimulation regime is selected based upon the woman's diagnosis and the IVF center's protocols. It's also possible to perform IVF without ovarian stimulation. This is known as natural cycle IVF or unstimulated IVF or modified natural cycle IVF. Usually only 1 or 2 eggs is retrieved. However, the vast majority of IVF cycles worldwide are performed with some type of ovarian stimulation because natural cycle IVF is associated with lower pregnancy rates and less drugs consumption. The ovarian stimulation regime described is an example and may differ from that recommended by your doctor because it will be decided according to your situation, according to your ovaries, number of your eggs, and semen sample. Many clinicians will prescribe maybe before treatment a birth control pill for the woman to take for 1 or more weeks before beginning IVF. This pill helps to prevent the woman's body from releasing hormones that could stimulate natural ovulation and that could interfere negatively with our treatment. Most programs ask that you call on the 1st or 2nd day of the menstrual bleeding to schedule an appointment for blood tests and an ultrasound. The 1st day of menstrual bleeding is considered the the first day of the cycle. On the day 3 to 5, you may be asked to have a pelvic ultrasound to evaluate your ovaries and blood testing to measure hormone levels. If these tests are okay, you will be given a date to start giving yourself injection with FSH to stimulate the growth of egg follicles. In most cases, you will give yourself an injection of FSH once per day, generally in the evening. The injection can usually be given under the skin rather than deep into the muscle. That makes it painless instead of painful. After a few days of injection, you will be asked to have a pelvic ultrasound to measure follicle growth and a blood test to measure hormone levels. Depending upon the results of these tests, the dose of FSH may be increased or decreased. Blood testing and pelvic ultrasound may be repeated several times during a cycle. The goal of stimulation is to have at least 2 follicles that are approximately 15 to 18 millimeter in size. The number of follicles that develops depends on the ovaries and hormone levels of the individual patient. In most cases, more than 2 follicles develop. In some cases, more than 20 may develop. When blood testing and ultrasound measurements show that the follicles are ready, you will be instructed to give an injection of HCG to trigger ovulation. HCG is usually injected under the skin at a particular time in the evening. This allows the follicles to be ready for egg retrieval and also for fertilization during a window of time, approximately 36 hours later. Egg retrieval. Approximately 32 to 36 hours after injection HCG, a procedure is performed to retrieve the eggs. The physician inserts an ultrasound probe into the vagina and then uses a needle to withdraw the egg from each follicle with a very special technique. The procedure takes approximately 15 to 30 minutes, depending upon how many follicles are present, and is performed under conscious sedation, light anesthesia. Serious complications of oocyte retrieval are uncommon, which makes this procedure safe. But side effects such as pelvic cramping, light bleeding, and vaginal discharge often occurs. If these problems are persistent or become severe, it's important to call a healthcare provider as soon as possible. Embryo transfer. Approximately 2 to 5 days after the retrieval, 1 or more eggs that have been fertilized, embryos are placed in the woman's uterus using a thin, flexible catheter inserted through the cervix. Most commonly, embryo transfer is performed on day 3 or day 5 after egg retrieval. The soft plastic catheter is inserted as gently as possible to minimize uterine cramping. Anesthesia is not usually needed for this procedure. Following the transfer procedure, the woman is generally encouraged to rest at home for several hours. Progesterone medication could be prescribed to improve the chances that embryo will implant and attach inside the uterus. This medication is started either on the day of retrieval or the day of the transfer. There are several ways to administer progesterone, with the most common being a vaginal gel or suppository, or an injection given into a muscle. What do we do in lab? Fertilization. We perform in vitro fertilization. After the retrieval procedure, the eggs are combined with sperm in a laboratory so they will fertilize. There are some techniques that we use for optimizing the fertilization. One of them is classical in vitro fertilization method and intracytoplasmic sperm injection, or IMSI. Conventional technique, in vitro fertilization method, the mature egg is placed in a laboratory dish with some of the sperm sample, and they are left for 16 to 18 hours within the incubator, and then monitored under a microscope to see if fertilization has taken place. ICSI method, intracytoplasmic sperm injection. In this method, once the eggs are removed, each egg is placed under the microscope and a single sperm selected, which is supposed to be the best looking sperm, is micro-injected by the embryologist into the mature egg. Currently, this is the preferred technique as it maximizes the chances of fertilization. The eggs are left within the incubator, and 16 to 18 hours after the microinjection, the eggs are monitored to see if fertilization has taken place. What do we do if there is no sperm? The term azoospermia means there is no sperm for fertilization. For such cases, we use TESE or micro-TESE procedure. What is TESE procedure? TESE is a surgical procedure carried out by a urologist or andrologist. It's usually performed under general anesthesia, and the acquired samples taken from testicles is examined in the operation room. If the embryologist decides that the sample is a viable sperm sample and enough for the procedure, operation will stop and the samples are sent to the laboratory for fertilization. What is micro-TESE? Microscopic or microdissection testicular sperm extraction is a surgical procedure performed in the operating room under general anesthesia to retrieve sperm for IVF or fertilization by using operative microscope. Microdissection TESE can improve sperm retrieval for men with non-obstructive azoospermia over those achieved previously with standard testis biopsy techniques. The main difference between TESE and microdissection TESE is that the micro-TESE process is performed by using the microscope to get optimal sperm sample. The urologist may distinguish sperm production more easily in the centers called tubules by magnification under the microscope. In this way, both the chance of finding sperm will be increased and the damage to the remaining testicle tissue will be minimized. There are high sperm retrieval rates with a micro-TESE, approximately 50 to 55%, except in some cases where large fragmentation and Sertoli cell only occur in some Y chromosomes where sperm production is not or seriously affected. What do we do in the lab again? We may perform oocyte freezing instead of embryo freezing. It's statistically proven that getting pregnant after the age of 35 is harder. Miscarriage rates are higher at older ages with older eggs. Women can freeze their eggs when they are still viable and in good quality. So if they wish to get pregnant at a later age and have poor egg quality, they will have the frozen eggs as a backup plan. With this method, you can conceive at the age of 40, for example, with your eggs collected from the age of 30 years, and you will have a higher pregnancy chance with the higher quality of a 30-year-old egg. Egg collection is not only for women who want to postpone gestational age, but also for women who have reduced or decreased egg capacity for medical reasons. There are some tests we can perform before transferring the embryo, before potential implantation. Advances in genetics and IVF laboratories now enable us to evaluate each embryo and whether they carry out the correct number of chromosomes and if they carry out normal arrangement of the genes to indicate they are healthy. It can also be used to identify a specific genetic mutation. We may do some tests which will give us the optimum results. FISH, RACGH, and NGS, next generation sequencing, are one of them. In this method, this is earliest known genetic methods of investigation. It focuses on the study of a single cell called the nucleus, which carries the genetic information. In RACGH is a method that allows the examination on the genetic structure of an embryo. The biggest advantage of the test is that it allows the evaluation of all chromosomes, either numerically or structurally. NGS is the ultimate test. This treatment and biopsy technique and timing for NGS is the same as RACGH. In cases where NGS is used, and embryos are frozen individually after embryo biopsy. If a suitable healthy embryo is found after the result, the transfer again will be carried out in a later cycle. Why you should choose our department or hospital? First, experience. We have 1,500 cycles to 2,000 cycles per year. And also we have a multidisciplinary team with perfect collaboration. We are a team with 3 IVF certified doctors. We are males and female doctors, and one of our clinicians has stem cell education experience in United States. We have 2 very good experienced doctors, urology doctors, and we have 2 embryologists, approximately 15 years experience, and 4 nurses, whom they will help you as soon as you want. We all understand about your journey and how you could feel going through this period. Some of us also experienced this. We will be here from the very first moment through your treatment period. We will evaluate every detail and every improvement according to current scientific developments and with our West experience. Our approach will be personalized due to your needs, clinical status, and will target the optimal results for you. We have high success rates and we have really good experience, and we have 70 to 75 pregnancy rates and 58 to 61% of retrievals, which is a very high number, resulting in live births. Embryo development is critical to the fertility success to those who have experienced a miscarriage, failed IVF attempts, age-related issues. Oocyte freezing techniques is also decisive for those who want to preserve fertility according to medical reasons, such as before chemo and radiation therapy. Our highly experienced embryology team and laboratory facilities will come over all the pitfalls that could prevent you from hugging your baby. Advanced genetic tests will improve pregnancy rates by helping us to choose the best embryo for you. Our highly experienced embryology team and laboratory facilities will come over all the pitfalls. Our surgical experience, our team members all are highly skilled for surgical procedures. Laparoscopy and hysteroscopies are all available options to improve our success. Fibroids, uterine anomalies, polyps, or endometriosis will not be an obstacle anymore. Facilities in our operation room are all worldwide quality. These advantages will make you closer to your baby with us. And also ultimate options for you, stem cell therapies. As we all know, stem cells are undifferentiated cells that exist in embryos, fetuses, and adults to produce differentiated cells. Stem cells have incredible capacities to regenerate and support tissues. For female infertility, stem cells are used for ovarian regeneration and oocyte generation in cases of early menopause. Live births are achieved with stem cell therapy. Stem cell therapies are all available in our clinic. Diet adjustments, psychological supports, and acupuncture treatments that could increase your chance and make you more comfortable during our treatment will all be available for you. And also, I want to add one more thing. Please do not hesitate to contact with us in any question, any concerns, or anything that's important for you. Please do not hesitate. Just text us. Thank you so much for your patience.
Hello, everybody. My name is Ergun Demirsoy. I am Chief of Cardiovascular Surgery Department of Şişli Kolan International Hospital, Istanbul, Turkey. My topic is minimal invasive complete coronary revascularization via left minitoracotomy. Over decades, median sternotomy has been a gold standard approach for treatment of isolated multivessel coronary artery disease. Everybody know that. From the 1967, almost all coronary case is performed with median sternotomy. But this traditional approach has been associated with sternal wound healing, leading to remarkable morbidity and mortality. In classical method, surgery is performed with the 20-25 centimeter incision, as you see. And since 2000, limited number of surgeons began minimal invasive techniques for cardiopulmonary bypass. But initial attempts was only for the single vessel disease, DIMA to LAD bypass. But here we describe this specific technique for left anterior thoracotomy through the third or fourth intercostal space for treatment of all group of patients with multivessel coronary lesions, which we recently have been routinely applying to our patients. Here you see the left side, the traditional heart bypass incision. As you see, in this case, the sternum is cut, whole sternum is cut. But in this minimal invasive technique, as you see, the procedure is done just intercostal space without cutting any the bone. This is very important. Since May 2020, I mean the last year, we started to perform the multivessel coronary artery bypass grafting routinely through the left thoracotomy in all patients. Development of new surgical maneuvers resulted in significant simplification of the whole procedure. Currently, we use this technique routinely regardless of the number of the grafts, quality of location, coronary targets, left ventricular ejection fraction, age, gender, and body mass index. I mean that we can apply this technique all the case without any contraindication. It is, as you understand that in this technique, the preoperative evaluation is very important for this as well, the conventional cardiac surgery. But if we decide the patient apply the minimal invasive coronary bypass surgery, additionally, the computed tomography was performed routinely in all patients. And on the other hand, aorta and major branches were screened for atherosclerotic disease, and also venous vessels were screened for absence of kinking and congenital abnormalities. In this minimal invasive coronary bypass surgery, also we use some different coronary bypass grafts, like the conventional surgery, such as the mammary arteries, lima or rima, radial artery, and saphenous veins, like a conventional surgery. But in conventional radial artery and saphenous vein harvesting require actually very long incision, as you see. This long incision may result sometimes the long-standing infection and unsatisfied cosmetics. In our also the same as you see, the radial artery, the conventional harvesting require very long incision and very bad scarring. So in our cases, we use endoscopic radial artery and venous saphenous vein harvesting. As you see, you see conventional radial harvesting, and this is the bottom one, endoscopic radial artery harvesting. Minimal invasive coronary bypass surgery can be done the two techniques. One of them on pump, the other name is it's called arrested heart. Also can be done off pump or beating heart. I would like to talk about the minimal invasive, the technical details of this technique. In this case, we have to use double lumen endotracheal tube. And on the other hand, also right jugular venous cannula is required. The patient position is very important. Later on, I'm going to show you the video. You will see that. Endoscopic radial artery and saphenous vein harvesting also the routine we use. Lima harvesting is performed via minithoracotomy and femoral exploration for arterial and venous cannulation. And on the other hand, also aortic cross-clamping with sheathwood clamp is applied via the second intercostal space. Here you see the surgical technique. As you see, the patient placed the supine spine position and with the implantable pad under the left chest. This facilitates the internal mammary artery dissection and heart exposure. And left arm was positioned along with the chest. Then left arm may be left out at 90 degree for simultaneous radial artery harvesting when necessary. And here you see the mammary artery harvesting. In that case, we use very specific the catheter for minimal invasive mammary harvesting. As you see, one of the most important part for this technique, as you see, it's very important. And here you see, I'm going to show you the short video, the whole procedure for technical details. As you see, before the surgery, we marked all the incisions. As I mentioned earlier, firstly, you see the first endoscopic radial harvesting. You see the radial harvesting. As I mentioned earlier, from the 1 or 2 centimeters skin incision, the whole radial artery can be harvested very easily without touching. It's very important for that case, one of the important part of our surgery. And this is not so, this really required a learning curve, not so easy to radial artery harvesting. Our team very experienced for that. As you see, the last, after finishing the harvesting, as you see. And here you see mammary artery harvesting also. A special rib spreader is used for that. It is impossible to harvest Lima with the conventional rib spreader. Should be the special. Yes, after harvesting, we are trying to start cardiopulmonary bypass. You see the tubing system. After initiation for cardiopulmonary bypass, using some tapes, we obtain some position of the heart. After harvesting of the heart, we start the bypass. In that case, we change, as you see, one of the, you see this right corner anastomosis. This is same as the conventional approach. This is another also. Using these tapes, also we can obtain some position of the heart to operate to approach target vessels. But this important one, especially the call it very important. This is another anastomosis. In this case, 4 bypass was done. This is Lima Elade anastomosis. You are going to see that. After distal anastomosis, also proximal anastomosis is done with side bias clamp. This is applying the side bias clamp for proximal anastomosis, as you see. And after that, and yes, as you see, the proximal anastomosis. And after that, the rest of the surgery, like the conventional one, and after hemostasis, later on, we close the patients. This is the same case before the surgery, the left side, the middle you see during the surgery, and this is the after 1 week later, the incision, you see the right side. This is another case, the post-op first day after surgery. He was 135 kilogram. This is very obese case. This is the day after, just the first day of the surgery. As you see, the patient move all arms. He can do everything. Also easy for him to cough, to the moving and the walking. He can do everything very easy. This is the first day. Actually, in case of the median sternotomy, it's impossible to do that kind of the movements case. This is just before discharging another case. You're going to see that. The same days we are discharging the patient in the 4th day. The most of the case, 95% is discharged in 4th day postoperatively very easily, because as you see, the patient looks very healthy and very easy. Every movement is done possible, and he can go home using his car. What is the main advantage of minimal invasive technique over the conventional technique? In the patient use, if you use the minimal invasive technique, the patient feel the less pain. Also, patient less ICU stay, because the day after 99% move to normal regular work. Also, when the operated patient, the conventional fashion, the patient stay minimum the 7 days, but in this minimal invasive case, the postoperative 4th day, most of the case easily can be discharged. And in this case, we use less blood products used. Also, in that case, risk of infection is very low. Also, another important factor for that minimal invasive surgery is the cosmetic results. Also, no one wants to very long incision in the chest or arm or the legs. That's why it's very important for some cases, especially young patients. Also, in this case, has a very fast recovery, and they can back to very short time the work and social life. I would like to show some case after surgery. This is a very nice lady. As you see the submammary incision, and in that case, you cannot see the patient from the front line. The other case also, the postoperative, some of them just after surgery, some of them 1 month later. As you see, the cosmetically, it's a very satisfactory result, as you see. The conclusion, the minimal invasive coronary bypass is very important. In our opinion, because of it had completely eliminated sternotomy and decreased the invasiveness of coronary bypass grafting, while preserving the key principles, complete revascularization and universal applicability for multivessel or diffuse coronary artery disease. In our experience, minimal invasive coronary bypass is safe and effective technique, and we routinely apply it for all patients, excluding very limited number of patients with porcelain aorta or who require isolated primary coronary bypass grafting. Okay, in case of any questions or any problem, you can easily contact us using these telephone numbers as you see here below. Also, you see my email address. Any question, any contribution, easily you can communicate with me. Also, the bottom side, you see our patient hospitals, the mail postal address. Also, easily you can reach us. Thank you for your attention. Bye.
Hi, my colleagues. I try to say something about new technologies and trends in radiation therapy. Radiation therapeutic journey is started with two-dimensional radiotherapy. Two-dimensional radiotherapy means that high doses surrounding normal tissue and high toxicity is limiting radiation doses. Normal tissue that couldn't be preserved while giving a high dose to the tumor also resulted a bad toxicity when the high dose was taken. And 3D conformal radiotherapy provided an advantage over the two-dimensional radiotherapy, which includes imaged guided target localization, and plans was made in computer 3D planning and include multiple beams, high conformity, and sparse surrounding critical organs over than two-dimensional radiotherapy, and less doses surrounding normal tissue. You can see here 2D and 3D conformal radiotherapy compared. For example, first picture in the tumor here, and this is the normal tissue, and they are get same doses. This is the 2D radiotherapy. And this is the 3D radiotherapy. Some of the normal tissue getting less doses. That's okay, but we want to make like this. For example, this is the blue one is tumor. This is the chiasm, and this is the brainstem. We want to deliver to here 50 gray, and we want to deliver here 54 gray. This is the organ at risk. But for example, here the green one is the highly proliferative tumor. We want to deliver here 70 gray. We want to make like this, but we couldn't in the 3D era. 3D radiation planning couldn't offer as many individual treatment opportunities as desired. For example, in these examples, this is the whole brain tumor radiation. This is the cochlea area. When we use the 3D conformal radiotherapy, we don't spare here. But when we use the IMRT technique, we protect here, and there is no any hearing disabled due to radiotherapy. New technique is IMRT. IMRT has some benefits. For example, there were treatments with better dose conformity and coverage to the target, hence reducing the probability in field recurrence, and better sparing and protection of normal tissue, hence minimize the degree of morbidity associated with treatment, facilitating the escalation of dose to improve local control. here you can see some examples of 3D and IMRT treatments. For example, this is the head and neck cancer. This is the tumor, and this is the risky area. For example, when we irradiated with this one, like 3D conformal radiotherapy, some of spinal cord getting doses is maybe dangerous for the patient. This is the normal tissue in the mandibula, get some doses, but when we use the YMET or IMRT technique, there is no any doses here and here. This is the prostate tumor. When we use the 3D conformal radiotherapy, you can see easily there are a lot of normal tissue getting some doses. But when we use the IMRT, there's less surrounding doses. IGRT means image guided radiotherapy, is a very precise radiotherapy. You can see in these images a green one. When we use the conventional radiotherapy, we irradiate whole of the green one, and the pink one is when we use the 3D conformal radiotherapy irradiated area. But we want to irradiate the tumor, this irregular shaped tumor. When we use the IMRT stereotactic radiotherapy and another stereotactic technique, we only irradiate it here. When we use IGRT position of patient based on internal bone marrow marked or implanted marker using X-rays, fusion of the X-ray images to digital reconstruction images from the planning CT. This is the simulation CT and the planning CT. They are fused, and we contour the tumor and irradiate it perfectly. I would like to illustrate the utility of the IGRT with an example. Here is the liver and the liver tumor. Liver tumor is nearly 100 cc. Here you can see. Whole liver volume is 1000 cc. And when we don't use the IGRT, we must irradiate it nearly 60 or 70, 100 cc area, which is include normal tissue. But our tumor only 100 cc area. But when we use the IGRT technique, our PTV or irradiated volume is 200 nearly cc, and PTV volume reduction is nearly half. Real-time tracking is made by respiratory tracking system, internal tumor motion X-ray images, and external fiducial motion infrared and LED camera system. And MR-Linac scans can be taken at the same time as radiotherapy is delivered. Our machine is TrueBeam STX. We can use this machine 3D IMRT and IGRT and stereotactic radiotherapy. You can see here a tumor in vertebra, and this is the spinal cord. We protect spinal cord and irradiated this tumor perfectly here. Some of examples stereotactic radiotherapy, you can see here in vertebra, thoracic vertebra, and the lumbar vertebra tumors here. We can irradiate it whole tumors the same time immediately. This is the plan of this tumor. And some new trends in breast cancer, I want to say, for example, multiple randomized trials in breast cancer patients compared normal fractionated, which is include 50, 25, and 28 fractions to hypofractionated radiotherapy schedules, which is include 15 or 16 fractions. Multiple trials about breast cancer provide sufficient information for the question whether hypofractionation is oncological equivalent in the setting of post-mastectomy radiotherapy and breast conserving surgery. And another new trend is a partial breast radiation. You can see in this image easily. For example, here we only irradiate the tumor area. Some treatable group, when we use these techniques, there is a lot of benefits for the patients. There are new trends in the prostate cancer. Prostate SBRT and hypofractionation here. Normally, prostate radiotherapy takes 8 weeks. But now, if the suitable patient here, the prostate SBRT takes only 5 fractions, 3 fractions per day, only 1.5 treatment time takes the prostate treatment. Some patients is suitable for hypofractionation. Hypofractionation takes 20 fractions. It takes 5 weeks, 4.5 weeks. Some prostate cancer is a locally advanced stage, and we want to irradiate whole involved node. We irradiate to involved nodes as SBRT techniques without any toxicity perfectly. This another new definition is about cancer is oligometastatic disease. Oligometastatic disease has been proposed as an intermediate state between localized and systemically metastatic disease. Early clinical studies show improved survival when radical local therapy is added to standard systemic therapy for oligometastatic disease. You can see here some new definition about oligometastatic disease. For example, here green one is our primary cancer, and after the first time diagnosis of primary cancer within 6 months, new metastasis here and here. This is the less metastasis. This is the synchronous oligometastatic disease. Some patients, for example, in green one is our primary tumor, systemic therapy gets and cured. After systemic therapy, before the 6 months, there are new tumors here, but it's oligometastatic. We say that to this metachronous oligorecurrence. And another definition is a metachronous oligoprogression. We irradiate it here, or the patient gets systemic therapy. During active systemic therapy, there are a lot of new metastases, but less than 5 metastases. And this is name is metachronous oligoprogression. And Saber Comet trial is present in ASTRO, is a very important trial for us. Patient with up to 5 metastatic lesions from any primary tumor site meeting inclusion criteria were randomized arm 1 and arm 2. Arm 1 is included palliative radiotherapy to any symptomatic sites, further chemotherapy at discretion of the medical oncologist. Arm 2 is a Saber to all sites with or without symptomatic, further chemotherapy as discretion of the medical oncologist. And this is the overall survival of this trial. You can see easily Saber arm, when we use this stereotactic radiotherapy to whole metastasis, has include overall survival benefit. It's very important practice changing thing in the radiation oncology and oncology area. Radiation therapy techniques divided two techniques. One of them teletherapy, another one is brachytherapy. Teletherapy is divided 3D conformal therapy, and new one is IMRT, and new one is IGRT. And another technique is stereotactic radiotherapy. Some machine make only stereotactic radiotherapy, gamma knife or CyberKnife or another Linac-based radiotherapy, but some machine is make only IGRT or IMRT, like this tomotherapy, trilogy, or TrueBeam. But TrueBeam, you can see easily every type of radiotherapy made easily. As technology improves, more details treatment is possible, such as the elaboration of the piece of wood, you can see. And decisions is cancer treatment cannot be made alone. We need each other. We take our decisions in our multidisciplinary management every time. Our include radiation oncology, medical oncology, surgery, radiology, nuclear medicine, and pathology, and clinical psychology, and palliative medicine. Thank you. Thank you very much. If you have a question, please don't hesitate to ask me. Thank you.
Турция – новая точка на карте мировой медицины. Ее расположение идеально. Она находится на стыке 3 континентов – Азии, Африки и Европы. Инновационное оборудование, квалифицированный персонал и доступные цены. Все это за последние 5 лет позволило Турции войти в 3 стран-лидеров по медицинскому туризму. Впереди только США и Германия. Самые тяжелые заболевания. Самые сложные операции. И своевременные вмешательства. Восстановление. И реабилитация. Продолжение рода. Красота и молодость. Весь спектр медицинских услуг вы получите в Турции. Доверьте нам самое ценное – ваше здоровье. Каждый заслуживает свое маленькое счастье, но не всем это удается. У 5% мужчин и женщин, у 48,5 миллионов пар диагностировано бесплодие. Эта проблема острым вопросом стоит в современном обществе. И выход есть – это экстракорпоральное оплодотворение. Только в Турции ежегодно проводится более 50 тысяч процедур при успешности около 65%. Почему люди со всего мира выбирают именно это место? Благодаря своим инновациям Турция предлагает новые методики вспомогательной репродуктивной технологии, которые помогают повысить шансы на удачное оплодотворение. Даже у женщин со сниженным овариальным резервом. Индивидуальный подход и подбор протокола для каждой пары с использованием прогрессивных методов ЭКО. В случае истощения овариального резерва или наличия мужского фактора бесплодия также существует возможность донорства. В программе донорства участвуют только сертифицированные доноры, проверенные на наличие инфекций, генетических и психологических заболеваний. В случае необходимости проводится предимплантационная генетическая диагностика, позволяющая исключить генетические нарушения эмбрионов и достигнуть главной цели – рождения здорового малыша в семье. Ведь каждый заслуживает свое маленькое счастье. И никаких «но». Успех борьбы с онкологическими заболеваниями много в чем зависит от ранней диагностики. Турция – страна, в которой за последние 10 лет уровень медицины вырос в несколько раз, а онкология стала приоритетом в лечении. Цены более доступные, чем в США и Европе. Турецкие нейрохирурги входят в первую пятерку команд в мире по использованию технологии гамма-ножа. Она позволяет убивать опухолевые клетки без оперативного вмешательства путем высокоточного радиационного облучения, существенно сокращает период реабилитации и предотвращает осложнения. Также в Турции практикуют выведение пациента из анестезии прямо во время операции на мозге. Ему задают вопросы, тем самым проверяя работу речевого аппарата, и проводят МРТ, чтобы убедиться, опухоль полностью удалена. Для опухолей простаты и женских внутренних половых органов радиоактивные лучи доставляются по специальным пластиковым трубкам непосредственно в опухоль. Эта технология позволяет сократить количество сеансов облучения и предотвращает образование ожогов. Рак – это диагноз, а не приговор. Травмы опорно-двигательного аппарата, головного и спинного мозга, параличи и детский церебральный паралич – вот неполный список диагнозов, когда реабилитация так же важна и необходима, как и основное лечение. Инновационное оборудование, квалифицированный персонал и индивидуальный подход. Всевозможные вспомогательные процедуры и дополнительное лечение. Физические нагрузки для окончательного выздоровления и профилактики. Но главным преимуществом турецкой восстановительной медицины является роботизированная реабилитация. Благодаря роботу-тренажеру человек, который долгое время был прикован к постели, может ощутить вкус ходьбы и даже почувствовать спортивный азарт с помощью компьютерной игры-симуляции. Параллельно с разработкой конечностей пациентов учат, как использовать восстановленные навыки движений в быту. Доверьте нам самое ценное – свое здоровье. И давайте шаг за шагом двигаться вперед. Уровень трансплантологии в Турции один из самых высоких в мире. Ежегодно здесь проводят более 5000 операций с пересадки органов. Это больше, чем в любой стране Евросоюза. Среди лидеров – трансплантация печени, почек и костного мозга. Как взрослым, так и детям. Трансплантация печени и почек в Турции возможна только от доноров-родственников, хотя бы 4-го колена. Для пересадки костного мозга сначала ищут доноров-родственников. Если таких нет, можно обращаться в донорские банки. Для пересадки роговицы пациенты могут воспользоваться услугами Национального банка доноров Турции.
I am interested in especially bone marrow transplantation in children. We can do.
Трансплантация стволовых клеток – еще одно направление, которое быстро развивается в Турции. Терапия стволовыми клетками показывает хорошие результаты при таких серьезных заболеваниях, как детский церебральный паралич, травмы спинного мозга, цирроз печени и некоторых аутоиммунных заболеваниях. Для многих пациентов это, если не шанс на выздоровление, хотя бы на улучшение качества жизни.
Doctors, I have been working on stem cell for the last 20 years, just stem cells. Today I would like to inform...
Медицинский туризм в Турции. Доверьте нам самое ценное – ваше здоровье.
The art of medicine is the heritage of Anatolia. You are in Turkey, the place where the first hospital of the world was founded and Hippocrates was born and grew up. In these lands, we treated the diseases with water, precious plants, and music. Our thousands of years of medical tradition reached a new level today with the advanced technology. But hospitality of Turkey and its air, useful for both soul and body, is still the same. Turkey attracts everybody by its nature, history, dynamic social life, as well as the best and most effective treatment possibilities since long time. With its high-standard hospitals and doctors known around the world, Turkey maintains its specialty of being the center of health of the region since long time. Because Turkey is at the intersection points of its continents. It is located at the center of Europe, Balkans, Russian, Middle East, and North Africa. Approximately 1 billion people can arrive at Turkey only with a few hours' flight. Turkish Airlines carries millions of people from 120 countries and 290 cities to Turkey by direct flights. There is a reason why so many people prefer Turkey. Because Turkey offers the newest technology treatment systems at the same time with the world. With its competitive price policy, it is among first choices of those who are looking for the top quality service with optimum prices. Turkey provides comfort with its high-standard hospitals during healing process, with its hospitals having Center of Excellence Awards and Joint Commission accreditation certificates, it maintains its privileged place in the region. An experienced team with 724 specialist services and air ambulances works for satisfaction of the guests. Experienced Turkish doctors who break grounds all around the world continues to control their patients after treatment. Thus, Turkey takes place on the top 3 in the World Health Tourism destinations. Turkey accommodates patients from 144 countries every year. In the risky treatments and operations required high technology. It uses robotic surgery. Marrow, organ, and stem cell transplantations are performed by awarded doctors through the latest technology. With innovative treatment systems such as inorganic organ production and transplantation, life-saving results are achieved. There is a progressive vision behind this success. Mustafa Kemal Atatürk, the founder of modern Republic of Turkey, started this vision by saying, "Entrust me to Turkish doctors." Today, Recep Tayyip Erdogan, President of the Republic, is still treated by Turkish doctors. Since the early years of the Republic, young doctors have completed their postgraduate education abroad. Turkish health sector has made a big progress with an investment of $30 billion in 15 promising successes in the treatment of common cancer and cardiovascular diseases. A complete healing is achieved in a short time by non-surgical treatments of the brain tumors. Children needing treatment in different branches such as blood diseases, marrow transplantation, heart surgery, brain tumors, etc. are also achieving health again in Turkey, because the best treatment methods are applied with a smiling and kindly approach. Services allowing the children to have a pleasant time facilitate treatment processes. Children, our most precious existences, are deserving of this special attention. Also, there are many treatment alternatives for those who want to have children in Turkey. Couples are enjoying having children and growing their family with infertility treatment, advanced genetics applications, and in vitro fertilization methods. Turkey is where the civilizations was born and continue. With its active city life, untouched nature, and majestic history, Turkey transforms your treatment process into a comfortable and pleasant holiday. .375 member organizations, which adopted ethical principles of Turkish Healthcare and Travel Council, work for happiness of the guests. We are at the intersection point of hearts and continents. Hope to see you soon. Right choice for your life. Turkey. Healing generations for centuries.
Hello, my name is Professor Betül Tabil. I'm working at Memorial Şişli Hospital Pediatric Bone Marrow Transplantation Unit. I'm a pediatric hematologist and oncologist. Today, I want to give you information about pediatric hematopoietic stem cell transplantation. Pediatric bone marrow transplantation or hematopoietic stem cell transplantation is now an accepted and increasingly successful intensive therapy used to treat a wide range of malignant, non-malignant, immunological, and genetic disorders in children. The conditioning of preparative regimens include high dosage of chemotherapy with or without total body irradiation. The conditioning of preparative regimens are extremely toxic and can cause some side effects. Now, some supportive therapies during bone marrow transplantations are using. For example, during peripheral blood stem cell collection, we use colony-stimulating factors. Also, intravenous or enteral nutrition, intravenous fluids to manage hydration needs, blood component administration, central line insertion, removal or occlusion therapy, pain control monitoring, and also prophylactic antibiotics, antivirals, or antifungal treatments and other clinical trial monitoring. Where does hematopoietic stem cell transplantation fit in the treatment of blood cancers? Actually, it is not used as a first step. First of all, we should control the cancer with few cycles of chemotherapy, and then we should perform hematopoietic stem cell transplantation. There is actually two types of hematopoietic stem cell transplantation. One of them is autologous transplantation, the other is allogeneic transplantation. We use autologous transplantation for especially solid tumors and Hodgkin lymphoma. In autologous stem cell transplantation, stem cells obtained from the patient, and stem cells are frozen in laboratory before conditioned chemotherapy. In autologous stem cell transplantation, rejection is never a problem. There will be fast recovery, and especially autologous transplantation is used for Hodgkin lymphoma, neuroblastoma, Ewing sarcoma, etc. In allogenic hematopoietic stem cell transplantation, stem cells from a donor are obtained, and donors should be HLA, human leukocyte antigen match. HLA match donor is needed. Therefore, rejection can occur in both directions. Rejection or graft-versus-host disease, a kind of complication may occur. This type of transplantation takes, in this type of transplantation, it takes longer time for immune system to recover. Allogeneic hematopoietic stem cell transplantation is used for some blood cancers, including acute lymphoblastic leukemia, acute myelodysplastic leukemia, myelodysplastic syndrome, and some in hemoglobinopathies, for example, thalassemia, beta thalassemia major, sickle cell anemia, and some primary immunodeficiency diseases. I want to mention about the indications for allogeneic hematopoietic stem cell transplantation in children. First of all, malignant diseases, including acute lymphoblastic leukemia, acute myelodysplastic leukemia, myelodysplastic syndrome, familial hemophagocytic lymphohistiocytosis, juvenile myelomonocytic leukemia, chronic myeloid leukemia, and some other hematological diseases, including severe aplastic anemia, Fanconi aplastic anemia, Diamond-Blackfan anemia, and some hemoglobinopathies, beta thalassemia, sickle cell anemia, and some other genetically transmitted diseases, for example, infantile osteopetrosis, are among the indications for allogeneic hematopoietic stem cell transplantation. And in some primary immunodeficiencies, including severe combined immunodeficiency, and also viscoelastic syndrome, leukocyte adhesion defect, Chidiac-Higashi syndrome, and adenosine deaminase deficiency, ADA deficiency are the others. Are the other primary immunodeficiencies which are indicated for allogeneic hematopoietic stem cell transplantation. And also some inherited metabolic diseases, including adrenoleukodystrophia, metachromatic leukodystrophia, Hurler syndrome, Krabbe disease, Morateaux-Slamy, Gaucher disease, are the other metabolic diseases indicated for allogeneic hematopoietic stem cell transplantation. And there is some indications for autologous hematopoietic stem cell transplantations in children. There are neuroblastoma, Ewing sarcoma, germ cell tumor, rhabdomyosarcoma, Lynch tumor, medulloblastoma, and retinoblastoma. In allogeneic hematopoietic stem cell transplantation, marrow or peripheral blood stem cells from an HLA identical donor, usually a sibling, is infused after an appropriate conditioning regimen, including total body irradiation and or chemotherapy, to reduce immune barriers and, in case of cancer, to destroy cancer cells. And we also use immunosuppressive drugs. Most often we use cyclosporine to inhibit or modify the graft versus host disease. In autologous transplantation, used in children with cancer, peripheral blood stem cells are removed from the patient. And these stem cells are cryopreserved. And after the children with cancer is given a very high dosage of intensive chemotherapy with or without total body irradiation, the marrow is reinfused to support the patient's hematopoietic recovery. Therefore, sublethal, very, very high dosage of chemotherapy can be given to the patient in the procedure of autologous hematopoietic stem cell transplantation. In 1986, the world's first successful bone marrow transplantation was performed for a 5-month-old child with severe combined immunodeficiency. According to the International Bone Marrow Transplant Registry, the median age of all recipients is 20 years. So approximately half of all bone marrow transplantations have been performed on children. Today, that number has increased to more than 48,000 transplants per year, and 18,000 allogenic and 24,000 autologous transplantations were performed worldwide per year. In this slide, I want to show that the donors option. I want to talk about donors. What do we mean when we say that someone is a HLA match? Actually, in hematopoietic stem cell transplantation, we do not need blood type match. We need HLA match, human leukocyte antigen match. HLA is a gene encoded at chromosome 6, and there is 6 main HLA locus: A, B, C, DR, DP, DQ, DR, DQ, DP. Totally 6 main HLA locus. If a donor is 10/10 HLA identical, it means full match donor. If a donor has 1 or 2 antigen mismatch, this donor is a mismatch donor. If a donor has HLA 5/10 identical, it means that this donor is haploidentical donor. HLA 9/10 or 10/10 identical related donors, it is the best donor, the best option, and these donors may be sisters, brothers, mother, father, or other relatives. If HLA 9/10 or 9/10 identical unrelated donors, it is the second option. Such type of donors can be found from international bone marrow or cord blood banks. And the third option is HLA non-identical related donors. Such a donor may be HLA 5/10 to 8/10 identical, and such a donor can be used for haploidentical hematopoietic stem cell transplantation. It is a third option. The first choice, HLA-related family donors. The second choice, HLA-related unrelated donors. And the third choice, HLA non-identical related donors. Yes, here in this slide, you can see that HLA-related, HLA-identical related donors and haploidentical related donors or we can also use mismatch unrelated donors. We can use such donors during allogenic bone marrow transplantation. Only 20 to 25% of patients will have a matched-related donor. Unfortunately, this is a very low rate. However, we can search the donor in international bone marrow banks, and the probability of finding a matched unrelated donor in the worldwide registries varies with the race and ethnicity of the patient. For example, there is a 50% chance for Caucasians, a 30% chance for Hispanics, and 10% or less chance for African Americans or Asians. The likelihood of finding an unrelated donor is high within their own race or ethnic group. The time to transplantation with a natural unrelated donor is up to 2 to 4 months. In Europe, there is about 4 million donors in unrelated bone marrow or cord blood banks, and in worldwide there is about 10 million donors in the others bone marrow or cord blood banks. Most potential donors for children are brother or sisters. Brother or sister is the most preferable donors because the complications will be very, very less, such as transplantation from actually identical sibling to the patient. The transplantation have many low risk. The risk of donation on the donor's respect are minimal. However, there is only risk of anesthesia. Putting a healthy child at any risk creates additional stress on the family. Many parents report this as the most difficult part of the transplant decision. Parents need guidance and help with these explanations and to provide ongoing support. I want to mention about haploidentical hematopoietic stem cell transplantation. In such a transplantation, there is some advantages. One of the advantages is there is almost universal donor availability. I mean that above 95% of patients will have a half-matched donor in immediate family. And the transplantation can be possible within 2 weeks, where transplantation may be performed very fast. And the donor remains available to collect other cells. For example, for donor lymphocyte infusion and any other cellular therapy, the donors remains available. Hematopoietic stem cell sources may be bone marrow, peripheral blood stem cell, or cord blood. There are 3 options. And in this slide, I want to summary the procedure of hematopoietic stem cell transplantation. First of all, stem cells are collected from the donor. And then the bone marrow or peripheral blood stem cells is taken to the for the processing to the processing laboratory, where the stem cells are concentrated and prepared for the freezing process. And then at third step, bone marrow or blood is preserved by freezing, by cryopreservation to keep stem cells alive until they are infused into the patient's bloodstream. At fourth step, high-dose chemotherapy and or radiotherapy, I mean conditioning regimen or preparative regimen, is given to the patient. After the conditioning regimen, tau stem cells are infused to the patient. All these procedures are performed in the allogeneic hematopoietic stem cell transplantation. Here we are collecting bone marrow in surgery room, our teams. And additionally, I want to mention about catheters. During allogeneic and also in autologous bone marrow transplantation, we need a central venous catheter. We use Hickman catheter with double lumen. First of all, the patients are taken such a catheter, and then we start conditioning regimen. Here, another schema. I want to summarize the transplantation procedure again. First of all, the patient is received conditioning regimen. Such a conditioning regimen is commonly immunoablative, immunosuppressive. This conditioning regimen may include total body irradiation and or chemotherapy. After conditioning regimen, hematopoietic stem cells collected from the donor is given to the patient. And to prevent graft-versus disease, we also give immunosuppressive drugs, especially cyclosporin A. Hematopoietic stem cell sources may be bone marrow, peripheral blood, or cord blood. In this slide, I want to mention about conditioning chemotherapy. Conditioning chemotherapy is different from the chemotherapy given at the time of diagnosis. Conditioning chemotherapy should be given just before the stem cell transplantation, and the purpose of the conditioning regimen is to remove any leftover disease, to make room for the donor cells, to suppress patient's immune system, and the conditioning regimen is classified as myeloablative, non-myeloablative, or reduced intensity according to the intensity of the regimen. How about hematopoietic stem cells count? Stem cell count is very important in hematopoietic stem cell transplantation procedure. In autologous transplantation, we should give 2 to 3 million per kilogram CD34 positive stem cells to the patient. In allogeneic hematopoietic stem cell transplantation, we should give 2 to 5 million per kilogram CD34 positive stem cells. In peripheral blood stem cell transplantation, 2 to 4 million per kilogram, and in cord blood transplantation, 100,000 per kilogram CD34 positive stem cells to the patient. These stem cells counts are very important. If such a number of CD44 positive stem cells are given to the patient, engraftment can be achieved. What is engraftment? Engraftment is the process by which hematopoietic stem cells make their way to free bone marrow niche where they can find optimal conditions to survive and proliferate. Engraftment is very important in the transplantation procedure. Neutrophil engraftment is defined as the first of 3 days of achieving a sustained peripheral blood neutrophil count above 500 per liters. And platelet engraftment is usually defined as independence from platelet transfusion for at least 7 days with a platelet count of above 20,000 per liters. After engraftment, the patients can be discharged from hospital. Yes, as a doctor interested in bone marrow transplantation, we desire engraftment, immune reconstitution, immune tolerance, and graft versus tumor effect. However, we should avoid graft failure, infections, graft versus host disease, and relapse. It is a very, very sensitive balance between graft versus host disease and graft versus tumor. Actually, in the donors' hematopoietic stem cells, there is some T cells, cytotoxic T, especially cytotoxic T cells. They make these type of cells may cause graft versus host disease. These type of cells also cause graft versus tumor effects. Therefore, a very, very little graft versus host disease is a desirable effect in transplantation, because it also causes graft versus tumor. In this slide, I want to mention about how do I answer, what are my chances, what is my chance? Actually, it depends on the variables of the transplant equation. For example, it depends on the indications, the state of the disease at transplantation. If the patient is in complete remission, the chance is high. It depends on the donors. If the donors in allogeneic hematopoietic stem cell transplantation, if the donor is HLA match-related donor or HLA match unrelated donor, the chance is high. However, in haploidentical transplantation, some complications may occur. It also depends on the source. For example, we can use bone marrow or peripheral blood stem cells. In peripheral blood stem cells, there would be graft versus there would be more common for graft versus disease. The conditioning regimen may be myeloablative or non-myeloablative, reduced intensity conditioning, or the graft versus disease prophylaxis. In graft versus disease prophylaxis, we can use cyclosporin A, methotrexate, or both of them. And in the haploidentical transplantation, we use endoxan cyclophosphamide, and the chances of healing depends a lot of variables. And I want to mention about the complications that can be seen in allogeneic hematopoietic stem cell transplantation. We see mostly infections during the first month, bacterial infection, fungal infection, viral infections. In the first 100 days, we can see acute graft versus disease. After 100 days, we can see chronic graft versus disease. In graft versus disease, donor cells thrive in patient's body, fight with patient's normal cells, especially skin, liver, gastrointestinal system, lungs, and eyes may be involved in graft versus disease. And also we can see veno-occlusive disease and rejection are the other rare complications. Here you can see the relative proportion of disease indications in allogeneic hematopoietic stem cell transplantation according to the EBMT survey 2018. EBMT is a European Bone Marrow Transplantation Registry. This registry collects all the transplantation data from Europe, including Turkey. Here we can see the relative proportion of disease indications in autologous transplantation according to the EBMT survey 2018. Autologous transplantation indications. And in this slide, you can see the allogeneic hematopoietic stem cell transplantation rates per 10 million population according to the EBMT survey 2018. Here you can see that allogeneic transplantation rates per 10 million population in Turkey. The rate is 201 to 300. Actually, it's a very good rate. The number of transplantation is gradually improved, gradually increased in Turkey in the last years, especially 10 years. Here you can see the allogeneic hematopoietic stem, autologous hematopoietic stem cell transplantation rates per 10 million population according to the EBMT survey 2018. The rate is 101 to 300. Here is our bone marrow transplantation unit. We have a 5-bed bone marrow transplantation unit at Memorial Şişli Hospital. Here is other rooms. There one single bed for the patient and the mother. Separate beds, toilets, and our wonderful team, our patients. We actually 75 hematopoietic stem cell transplantation were performed in 3 years in our transplantation unit. Hematopoietic stem cell transplantation from HLA identical family donors in such a transplant, our success rate is very, very high, 95%. Overall survival is 86%. Transplant-related mortality is 10%. According to the literature, this is a very, very good success rate. Thank you very much for your attention. If you have any question, could you please write or ask? I'm waiting for the questions. Thank you very much.
Ladies and gentlemen, dear audience, my name is Dr. Pelin Basım from Istanbul Medipol University, General Surgery Department, Breast Cancer Surgery Section. Today, my subject is new approaches in breast cancer surgery. First of all cancer are dreadful diseases. So, especially the breast cancer is the most common type of malignant diseases in human gender. And malignancy means that the cell grows uncontrollably and harmfully for the patient. Breast cancers constitute approximately 1/3 of all female cancers and 1/5 of cancers death in female gender also. It's also seen in 1% of male gender, and the survival is approximately 2 to 3 years without treatment. A breast tumor needs approximately 5 years to become 1 centimeter, or it has 30 times of doubling time. We have some dilemmas in the treatment of breast cancer. New dilemmas in the treatment of breast surgery stems from anatomical concept of cancer spread to biological concept of cancer spread, and from aggressive surgery, chemotherapy, radiotherapy to targeted and conservative treatments, especially patient-tailored treatment models. What are our main treatment options? We can classify them as surgical treatments. It may be a curative intent or palliative intent. Chemotherapy, we can use it as adjuvant therapy or neoadjuvant therapy. Radiotherapy models, hormonal therapies, immunotherapies, and palliative care for metastatic patients. We have also many different types of surgical options. Mastectomy means removal of all the breast tissues with skin and nipple also, so the patient remains with one breast. So it's the most dreadful conditions of this surgical treatment. The breast conserving surgery means that excision of the diseased part of the breast. It may be a lumpectomy or quadrantectomy where the tumor is located. So it's a more acceptable type of surgical treatment, especially for the patient cosmetic results. And we have a new technique, and for the last decades, subcutaneous mastectomy technique. It may be skin sparing or nipple areola sparing, which means that we are filling out the mastectomy area with some oncoplastic techniques, so the patient has a new breast after the operation. We have some relative indications for mastectomy procedures. I should say that inability of the patient to obtain a radiation therapy, multicentricity or multifocality of the tumor, which means that there are many tumors in many different sites of the breast tissue, large operable breast cancers unfit for radiotherapy after the surgery, BRCA positivity, which means the genetic susceptibility for breast and ovarian cancers, and skin involvement, especially white skin involvement that we cannot treat with breast conserving surgery. Are these absolute contraindications, or can we do something else for these patients? We have a clear demonstration here that you can see very easily. We know that obtaining clear margin while doing the surgery is very important, because more than 40% of the patients have clear margin positivity after the operation in the final pathologic specimen. So we should clear the breast tissue at least with 2 centimeter margin during the surgery, and it's very acceptable for the patient's recovery. We have some traditional paradigm in the treatment of breast surgery, especially multicentric or multiple focal breast cancers were used to be considered a relative contraindications for breast conserving therapy in the past. The reasoning is that perceived high risk for in breast recurrence, since it's assumed that in multifocal or multicentric breast cancers, the risk of more invasive foci in the breast is greater, and the radiotherapy is less effective for these kinds of patients. Another reason is the bad cosmetic results that we attend, because we need wider excisions in these patients, and these wider excisions may cause a bad cosmetic result that aggravates the patient's outcome, and we need larger boost volumes that ends up with more fibrosis in the breast tissue, again with bad cosmetic results. So to decide the individualized treatment plan, we have a tumor council meeting every week with newly diagnosed breast cancer patients, a thorough evaluation of the existing patients in every week, complication management of these patients, and counseling mechanisms. For example, patients coming from all over the world and counsel us about their current presentations. So we have a multidisciplinary team approach in this area. We are coordinatively working with some branches, mainly radiology, pathology, radiation oncology, and medical oncology. So what are we doing now here in our hospital? We are using high-resolution imaging modalities with expert radiologists to obtain the best surgical outcome. We have a good and attentive perioperative pathologic examination of the specimen by expert pathologists. And for an acceptable cosmetic result with oncoplastic surgical methods or real-time cosmetic operation with an experienced plastic surgery team to obtain the best result for the patient and patient satisfaction. We are working with expert radiologists to guide the tumor, usually especially unpalpable ones. So we are using every techniques that can be used during the breast examination. We are using high-resolution mammography. We are using also a high-resolution ultrasound imaging to detect the tumors. But the use of MRI is associated with increased subcutaneous mastectomy rates because we find more simultaneous breast tumors within the same breast. So it increases the simultaneous breast reconstruction techniques by various patient-tailored methods. We are trying to make an analysis of recurrence according to the patient by various analytic size. For example, tumor size, histopathology of the tumor, grading of the tumor, intrinsic subtype, age of the patient, and the surgical technique that could be preferred. So we are using these all the parameters to make a recurrence risk assessment to define the patient's best surgical option. And also, we are trying to analyze the aesthetic result and patient satisfaction according to tumor location, surgical technique itself that we are using during the operation, resection volume, which means how much breast tissue will be removed out during the operation. Also, the age of the patient is important because, especially in younger ages, we are giving more importance to the aesthetic results. And body mass index of the patient is also important because with higher body mass indexes, we have less comfortable aesthetic results. We have some oncoplastic techniques. We are performing oncoplastic breast surgery in patients having breast conserving surgery in our clinic. So this enables the best cosmetic results for the patients. Oncoplastic surgery, combining with lumpectomy, quadrantectomy, with local or regional tissue rearrangements so that the breast should be conserved and reshaped to avoid significant deformity after the operation. We have 5 major principles for oncoplastic techniques. We are using mostly the glandular rotation technique during the operation. We have dermoglandular rotation, which involves also the skin portion. We have tumor-adapted reduction mammoplasty for big breasts. We have thoracoepigastric flap, and we have advancement flaps in some selected patients. But we are most commonly using glandular rotation, especially in selected patients. You can see here that approximately 64% of the patients in our clinic are undergoing glandular rotation mammoplasty, which is a very satisfiable technique for patient cosmetic results, and the surgical outcome is approximately 80%, more than 80% satisfactory. What is a breast reconstruction? Actually, the breast reconstruction is regarded as an integral part of modern-day breast cancer management in these days. We have various techniques available, including silicone implants, latissimus dorsi myocutaneous flaps, transverse rectus abdominis, myocutaneous flaps, and gluteal preflaps. Most commonly, we are using the first two ones, silicone implants and latissimus dorsi myocutaneous flaps, which are more easier than the others and which gives less deformity in the breast. And we have the best cosmetic results with these techniques if the patient is suitable for these techniques. You can see here that approximately 90% of our patients were satisfied with the surgical outcome. We have another important technique for the evaluation of the axillary region with sentinel lymph node biopsy, especially in early breast cancer, in unproven lymph node metastasis. You can see here that in early carcinoma of the breast, generally, histopathological positivity of axilla on axillary lymph node dissection is approximately 30 to 40%, which means that when we remove all the axillary lymph nodes during the operation, only 1/3 of the patients have positivity. So this means that 2/3 of the patients, 60 to 70% of the patients with early primary breast cancer patients are undergoing unnecessary axillary lymph node dissection, unnecessary removal of the lymph nodes. So especially axillary lymph node dissection is associated with very high morbidity. So we are trying to enable the patients to avoid this type of operation. We have some do's and don'ts because we have some adjuvant radiotherapy choices after the operation. So we are trying to eliminate the patients to do the lymph node dissection. Axillary dissection is not something innocent, is not an operation innocent for patients because it's associated with postoperative impairments. It may cause an incisional pain, lymphedema due to removal of all axillary lymph nodes, which disrupts the normal circulation of lymphatic drainage, weakness of horizontal adductors of the shoulder, serratus anterior. It may cause difficulties in range of motion of the patients, especially in the shoulder mobility. It may cause also postural asymmetry and dysfunction of the patient, so it's not an innocent technique. You can see here that sentinel lymph node is the one which is primarily targeted by the tumor. So the primary aim during the surgery is to find this first lymph node to be infiltrated by the tumor. We have some technical issues in sentinel lymph node detection and imaging. We have some dyes and radioactive materials which we use with probe to detect the sentinel lymph nodes. We have some options to use. We are deciding, first of all, what tracer will be used during the operation, what injection site will be used during the operation, or will we inject large or small volume of dye or radioactive material. Patient-tailored injection is the first aim. All the treatment models are patient-tailored, is decided according to the patient's situation. You should find the tumor ultrasonographically if needed, especially for unpalpable tumors of the breast, and it probably needs a radiology expertise. So we are working with very expert breast radiologists in our clinic to find and both the tumors and if there are satellite lesions. You can see here how we are doing the sentinel lymph node biopsy. This is a radioactive colloid material injecting during the operation to the breast tissue. Here you can see that we are injecting the material around the tumor. We can give it subcutaneously around the areola or nipple complex, but we are generally preferring the technique of injection inside the tumor or periphery of the tumor. So, and thereafter we are opening the area and we are using the probe, and the probe is finding the tumoral area by a loud noise, and it gives a loud noise, and we are finding the tumor by this way, sentinel lymph nodes. So we are putting the probe inside the operation site, and we are trying to be sure that all the lymph nodes targeted by the tumor cells, infiltrated by tumor cells, are found during the operation. So we are taking out the lymph nodes thereafter, and we are sending them to the pathology department, perioperative frozen section, perioperative evaluation of infiltration of tumor. This is another option. We are using now here blue dye. We call it isosulfane blue mostly. We are calling it namely blue dye. We are giving it peripheral to tumor or subareolar region, from the subareolar region. So we are checking the bluish discolored lymphatic channels here, and we are finding the lymph nodes, targeted lymph nodes, and dyed with this bluish color. You can see more clearly that there are here 1, here 2, here 3 bluishly discolored lymph nodes. These are the sentinel lymph nodes, I mean the first lymph nodes affected by the tumor in the axillary region. So we are removing these lymph nodes and we are sending to the pathology department. You can see here the bluish discoloration of the lymph nodes. We are sending to the pathology department, and by experienced pathologists, these are examined during the operation, and they are giving the results if there is any tumor cells inside these lymph nodes, or if not. If there's nothing in these sentinel lymph nodes, this means that there will be nothing in the left of the axilla, in the residual axilla. So we are closing the axillary operation site. If there are metastatic lesions in this lymph node, we are performing the axillary lymph node dissection. So which mode of detection is preferable for us? We can use probe detection and imaging. We are mostly using this type, the first image that I showed you. We can use only the probe detection, or we can combine these methods, blue dye alone or in combination with probe detection. The most commonly used technique in our hospital is the combination of blue dye with probe detection, which gives us the best results. You can see in the next slide. Here you can see that imaging positive means that 84% of positivity in the final pathology report. With probe, we are approximately 97% of positive results, and with blue dye, 91%. So when we are using both probe and blue dye, the histopathologic assessment is giving us a 99% of accuracy. So the best technique is using blue dye and the probe concordantly. In case of radiotherapy, here we are trying to make less radiation, because the future is going to that way. The future is less radiation, sometimes better. We are using some techniques, whole breast versus partial breast radiation, which is called brachytherapy. We have a shorter course of hypofractionated radiotherapy for especially elderly people over 60 years of age, which means that it takes 15 days approximately. And we have 3D conformational radiation planning for these patients. But we have a newest technique, intraoperative radiotherapy, that we can use it during the operation, and the patient doesn't need any other radiotherapy after the surgery. You can see here the device. This is a radiotherapy device. There are some equipment over this portion you cannot see here, I know, but because it's placed within the cavity that we are removing the tumoral tissue, we are placing the head of the radiotherapy device in the cavity. So we are waiting for 30 to 45 minutes for radiotherapy until it's given for age and body mass index to the patients. So we are waiting for 45 minutes approximately, and the radiotherapy is finished during the operation. So this patient will not need any other radiotherapy method after the operation. So we give the chance of reduce the treatment plan for a patient. So you should take home from here that optimal imaging is very important in terms of both diagnosis and treatment planning of the patient. And we should consider neoadjuvant chemotherapy, especially to shrinken the tumors and to give a patient with especially axillary lymph node positivity a chance to kill the axillary lymph node metastasis. And we can use intraoperative radiotherapy in appropriate cases. And we can use complete excision techniques combined with oncoplastic methods to achieve the best cosmetic outcomes. Surgery only is one sub-step of the multiple steps in breast cancer treatment. Thus, both a diagnostic and oncological expertise are indispensable and a definite requirement for the patient-tailored treatment. Thank you for listening. Thank you for joining us. Here in Medipol University, we are waiting for your questions or consultations. We are here to help you. If you need help or if you have questions about these, you can ask us whenever you want. We are willing to help anybody who needs help about breast cancer surgery.
Hi, everyone. I am Dr. Süleyman from Cologne International Hospital and bone marrow transplanter and hematologist. We have good hospital and A+ hospital in Istanbul. In bone marrow transplant unit, every time need A+ hospital. A+ hospital is A+ hospital necessary in all clinic situation, all laboratory examination needed. Who need for the transplantation in Turkey indication? Patient with a diagnosis of the acute and chronic leukemia, lymphoma, multiple myeloma, some solid tumor or cancer, aplastic anemia, myelodysplastic syndrome, and thalassemia, and some other metabolic disorders, other treatment refractory diseases. During the bone marrow transplantation, all the bone marrow transplant patient necessary evaluated and full lab and body examination. And also allogeneic transplantation needed HLA examination. If it is suitable for the transplantation and all this patient is informed about the procedure to be performed and chose for the transplant patients. In our hospital, bone marrow transplant unit is do all transplantation procedure. Generally, for Turkish citizen and foreign national. And besides the transplant success rate, we are, and 97% is big answer for yours. Is success rate is very good for us and for the world. How can I get the stem cell and which one source do we use it? And stem cell collection, and how do I get the stem cell? And firstly, in autologous and allogeneic and syngeneic from the brother and sister, and unrelated and mismatch and haploidentical transplantation, and sometimes refractory patients needed CAR T-cell treatment. And the experimental side, and sometimes we use stem cell engineering for mesenchymal stem cell transplantation and dendritic cell transplantation, mostly for the GVHD, mostly GVHD, graft versus host disease procedure. Which one do we use this source for the stem cell? 100% and bone marrow, directly collecting bone marrow, and mostly we use the peripheric blood cell. And from the bone marrow bank, cord blood, and from the lab, embryonic stem cell, and fetal liver and fetal bone marrow, all of these experimental situation for the laboratory. This is hematopoietic stem cell chart and cascade for the primary stem cell and after, ended neutrophil, thrombocyte, and erythrocyte. You know this mostly. I know that the stem cell is transform the somatic stem cell. For example, for the somatic stem cell and dermatologic stem cell and enterocyte and fatty cell and chondrocyte, endothelial cell, neuronal cell, astrocyte, and liver cell, etc. We know this. Stem cell transform all somatic cell. Peripheric stem cell, we use mostly peripheric stem cell for bone marrow. Normally, it's in bone marrow side, stem cell is 101% for the bone marrow, and peripheric stem cell 1001 peripheric stem cell. We have it all this body. For the autologous stem cell collection, and we needed mobilization. For the mobilization, we use this chemotherapy cytokine in autologous transplantation patients. After mobilization time, approximately 10 and 15 days, collecting peripheric stem cell, collecting for peripheric stem cell by the leukapheresis and apheresis machine. This is apheresis machine and set and apheresis bed. This area is apheresis area. Bone marrow transplantation, mostly autologous, allogeneic, the subtype, myeloablative, non-myeloablative, and unrelated, we say that. And you know this, many internet sites comment this experimental stem cell transplantation. And maybe next time, next 20 and 10 years after, maybe spare part, use it. In allogeneic transplantation, for example, firstly, we will start TBI or some chemo, approximately 3 days, 10 days, sometimes 15 days, and started -10, -7, etc., like this table. 0 day is transplanted day. For the allogeneic transplantation, we, on the other side, we will prepare some donor, brother and sister, and other donor, allogenic and unrelated donor. we needed to prepare for the stem cell. Autologous transplant, and if the patient needed chemo and started chemo and cytokine, sometimes in the remission for the autologous transplantation, only we use cytokine. This table is chemo plus cytokine, and approximately chemo and cytokine after 15 days we collect, and after the only one cytokine, if I use this, after 5 days we collect stem cell. In summary, hematopoietic stem cell transplantation clinical indication. Hematologic diseases, all malignant and some benign hematologic diseases. And myeloproliferative patients, acute leukemia, chronic leukemia, many patients for the hematologic diseases, if it is malignant side. And solid tumor, mostly we use solid tumor, and some refractory patients needed CAR T-cell treatment, some childhood solid tumor. This congenital immunodeficiency status situation, and some metabolic diseases like Gaucher diseases, mostly major hemoglobinopathy, and some autoimmune diseases, for example, systemic lupus erythematosus, and some antiphospholipid syndrome for the treatment refractory to the treatment for autoimmune diseases, and these experimental ones. Maybe every time change this situation, and some neurologic diseases, some other diseases. This is a very good situation. Sometimes we collected apheresis product for the autologous transplantation, sometimes allogeneic transplantation. Some special site, this area is collecting stem cell and storage. We send the storage area. In the storage area, this stem cell 4 centigrade is 72 hours storage. Only 72, but in the liquid nitrogen, it's endless. In this area is liquid nitrogen area. Cell engineering, all experimental area for the stem cell. Sometimes some people use this ischemic heart diseases, some refractory patient is peripheral vascular diseases, some neurologic diseases. You know that this area all now experimental. And oncologic disease as well, some treatment restriction we have, but more vaccine and CAR T-cell treatment, now we use this, some refractory oncologic patients. Maybe maybe next time in 10 years, after 10 years, 20 years, I don't know now, but it's very quick procedure and very quickly follow it. And stem cell and the spare part, this is 1980 is bone marrow transplantation, say experimental, but is now classical treatment. Maybe after 10 years, stem cell is make spare part. Okay? Thank you for joining us. If any question, please ask the center and email, etc. Thank you.
Hello everyone, I am Professor Koray Acarlı from Istanbul Memorial Şişli Hospital. I am hepatopancreatobiliary surgeon and at the same time I am the director of Organ Transplantation Center in this hospital. Today I want to share our experience in liver transplantation with you. So, to begin with, if you ask me what is liver transplantation, I can only tell you that the one and only treatment for end-stage liver disease. Because if you have an end-stage liver disease, it doesn't matter what is the cause. There is only one cure for that. It is liver transplantation. If you look to the global data, this is a data from Global Observatory of Organ Donation and Transplantation. Turkey is at the moment on the 5th rank in liver transplantation in terms of total liver transplantation, which includes total deceased liver transplantation from dead donors, from living donors, and also dominant donors. But the other important thing is that if you go to living related or transplantation from living donors, actually Turkey goes up to the 2nd rank, because the reason for that is because in Turkey there is not enough organ donation at the moment. What we have done is we overcame the problem in jumping into this living organ transplantation business actually. So if you also look to the European Liver Transplantation Registry, you see that Turkey is among the 6 countries who are leading transplantation in Europe, actually. But one thing is very important in here. All others are doing mainly cadaveric organ transplantation, which means from deceased donors. Our success or our numbers are 80% from living related organ transplantation, liver transplantation from living donors. So who am I? Actually, in Turkey, liver transplantation started in 1988, but it was like not blooming everywhere. It is only one center doing one case a year kind thing. And my first liver transplantation I have done in 1992. And he is still alive. This is very surprising thing for a surgeon, actually. The first transplant, still alive. So basically, I am a little bit like a historical object in this liver transplantation business in Turkey. But the other thing is, until 2000, there was only few cases, few centers, but starting with liver transplantation from living donors, starting from 2002, it really increased dramatically in terms of center number and also transplant number. If you look at this slide, at 2002, there was only 13 liver transplant centers in Turkey. Altogether, we have performed 159 transplants. But nowadays, this is 2019, have almost 45 liver transplant centers doing 1,700 something liver transplantation, and 1,345 of them are from living donors. So this table of EALT, European Liver Transplant Registry, shows, it is not my table, it is their table, shows that among Turkish transplant centers, Memorial Şişli hospitals, where I am the director, the Memorial Şişli Hospital is the second biggest center in Turkey. The first one is a university hospital, so we are a private hospital actually. This is also something very important, but I think very important and difficult thing to do basically, and to achieve these big numbers. So what we do actually, you know, what we don't want that the people has to continue to live with this kind of livers. For those who never seen a liver like this, I'll tell you these are cirrhotic livers, or cirrhotic livers from different sicknesses, and we don't want people to live them, because if you live with this liver, you may end up like this. Ascites in the belly, vessels are like that, you cannot move yourself, there are a lot of jaundice and everything, but this is like a miracle. After a few months, you will be staying like this, you know, and very healthy. So liver transplantation is like very different, with like night and day kind thing, you know. On one, if you don't get a transplant, you may die in very close future, and otherwise you are a healthy person. And also these children, otherwise they cannot find any organ from cadaveric source. So fathers and mothers, one more time, are ready to give birth to their child again while donating a part of their liver to their child. It is very emotional pictures, actually. So why we do this? We don't want to leave these small people untreated. So they should be like this instead of that. On the right-hand picture, you see somebody like how it looks after the transplantation. So what kind of liver transplantation we are doing at the moment? As you all know, the liver transplantation is an orthotopic transplantation, which means you take the sick organ out and put the new organ in the same place. This we call orthotopic. On the other hand, there are heterotopic transplantation. Heterotopic transplantation means you don't have to take the sick organ out. You put the new organ to somewhere else. For instance, pancreas transplantation, kidney transplantations are heterotopic transplantations. And then we do the orthotopic transplantation, liver, but there are two sources basically. One, deceased donors. There are brain death or circulatory determination after circulatory determination of death. So these are coming from cadavers. We can say that we use these either full size, or we can divide these livers into using right lobe, left lobe, we can say 2 persons life, or right part or left lateral segment, we can again use 2 persons life. But since we cannot overcome, even in the world, now the world is nowadays changing a little bit their attitude towards to do living donor liver transplantation, because nobody can overcome this organ scarcity problem. There are always more patients than organs available. So we can obtain livers from living donors. So from a totally healthy person, we can take a right lobe or left lobe or left lateral segment, which is a left part of the left lobe actually. So this is, here you see a cadaveric organ. This is a cirrhotic liver taken out and they put a new healthy liver in. But cadaveric organs, since there are not enough organs in our country, and anywhere else also, by Turkish law, we can only provide our citizens with cadaveric organs. We cannot give organs to a foreigner. So the mainly, and even though even in Turkey, we are at, as I said before, 80% of our person, or if left lobe is a smaller part, like 30% of the liver, so you can give it to a smaller person, or left lateral segment, left of left kind, we can explain it like that, to children. So here you see a original line of how we cut the liver. This part is the right lobe, this part is the left lobe. So after transplantation, if you transplant the right lobe, the left lobe remains in the living donor, or you transplant a left lobe. That means the right part of the liver remains in the donor. So this is the left of left, which is left lateral segment. It is very tricky to transplant these very small children, because even though this is the smallest part that we are taking from a living donor or from a cadaveric, doesn't matter, but you see on the bottom of the slide that even if smallest part of the liver is sometimes too big for the child, so it is very difficult to close the belly. If you do that, the intra-abdominal pressure increases, and that ends up with dysfunction of the liver. So this is a very tricky business, especially in pediatric patients. So I know from my experience that everybody thinks that one day, if I get sick, if I get cirrhosis, if I get end-stage liver disease, there is a liver transplantation, I can get a liver transplant. But it's not. It's not like that. Liver transplantation is not for everyone, because there is an age limitation. So although it is not, it is very changeable from center to center, but basically half year of age until 70 years, we can transplant, but we cannot transplant, we don't transplant a newborn patient. We don't transplant at 80 years patient, basically. Sometimes there are some technical issues that prevents us to make a transplant. Occluded vessels, for instance, especially when portal vein. Sometimes the patient needs a liver transplant, but it's very sick, like heart disease, lung disease, kidney disease, and that kind of expert says us, come on guys, you cannot transplant this patient. Or this patient might have some extra hepatic malignancies, which prevents us to do a liver transplant. Sometimes there are hepatic malignancies, which are always coming together with the chronic liver disease. Even in advanced hepatic malignancies, we cannot transplant the patient. So it's not like this. The liver is occluded with occupied with the tumor, so change this and finish the issue. It's not. And beyond of this, liver transplant from living donor is twice more difficult, or we are trying to do it very in restricted rules. So additional to rules before, experience very important. Now you go all over the world, not liver transplantation from living donor is not possible in every country, in every hospital. So you need an experienced team and a hospital, and also you need to have an appropriate donor, which means most of the time I hear, I have a patient and the donor is ready. No, the donor's will is ready. So to be a donor needs a lot of workup, studies, and then graft to body mass ratio is very important. So, for instance, if you have a 500 gram of liver obtained from a living donor, you can save a 50 kilo person's life. If you have a 700 gram liver, you can save like 70 kilo patient's life. So mostly we are having patients that they 120 kilo, coming with his child like 50 kilo, very small liver. You cannot do that. So please take this into consideration. Liver transplantation, both are eye context transplantation, but cadaveric and live organ transplantation are totally different things. So liver transplantation can be sometimes also very difficult, very bloody operation. As you see here, these are all from one operation. I don't want to remember that night anymore, but it is, sometimes it is. So, and also you need a lot of experience about. There are a lot of technical issues to deal with, new reconstructions to do this operation to achieve a success. So after brief summary of this, you can, or anybody can ask that, why are you doing this? What is the purpose of doing a liver transplantation, and what is your success rate? So, you know, end-stage liver disease means if you don't transplant them, the chance of living of these persons to live next year is like less than 50%. They are almost dying. So you have to save these patients. If you, here you are seeing our overall survival rate. Until now, which is not until now, until end of 2020, we have performed 1,227 liver transplantations with an overall survival 77.3. But if you look into 1, 3, 5 to 10 year survival, 1 year survival is 85%, 3 year 81%, 10 year survival 73%. Now remember the number I gave just before this slide. So instead of less than 50% chance to live next year, 70%, 10 year survival. It is very important to do that actually, and it is not like something any operation. It's not like any operation. It's a life-saving operation. But giving that survival rate naked like this, you cannot compare. There are maybe good results, but how are these results in compare with other centers? Again, this is the European liver transplant registry numbers. There are thousands of liver transplantation from all over the Europe. So they have divided the patients into 3 groups, 18 to 45 years, 45 to 60 years, 60 to 79 years. The black numbers are from average of European liver transplantation. The red ones are my numbers, my institutional numbers, which you see that these red numbers, with some exceptions, are even better in terms of 1, 3, 5 to 10 year survival rates. And there are another additional issue in that. We are comparing apples and beans. So, you know why? Because we are doing mostly organ liver transplantation from living donors, which means high difficulty, more morbid operation. In spite of this, the success rate, as you see, is good enough to trust. Another issue, which is not for everyone. This is our success, I guess. So if you look to the European liver transplant registry again, the proportion of children transplanted children, liver transplanted children, are varying. On the right column, you see that the highest rank is 25% all transplants, but usually it is less than 15%, right? So in Turkey, it is 19%, a little bit more. Why? Because they are doing organ liver transplantation from living donors. So again, evolution of the number liver transplanted reported in the European liver transplant registry, if you consider the children, Turkey with the yellow line, again, among the 6 giants are almost leading them. This is the number of reported numbers. But anyway, what I'm trying to tell is, this is my left hand. You see that? My left hand, my thing here. So these small children even are transplantable. Otherwise, they cannot find a solution. They can mostly not find a donor to get transplant, and we are losing this patient. But in this life from organ transplantation, with organ transplantation from living donors, you don't have to wait until to get a liver, or you don't have to lose your child until waiting for a liver. So a transplantation from a live donor can be life-saving, but even in those very small children. It is very difficult because even on the left upper part, you see that this is the smallest part of the liver we are taking from a live donor. But even that smallest part is too big for the child, for that size of child. So we have to cut it, to make it smaller, to fit it into the body of the small child, actually. So this is the whole part of it. So since it is too big, we need to try it to make smaller. There are a lot of techniques I am using to make it small. But anyway, doing that, if we can save the child's life, you see, that part goes garbage. We use that part to make this work. So are we also successful while doing pediatric liver transplantation? Beforehand, I have to say that remember that proportional between pediatric liver transplantation and other transplantation. I told you that it is all over less than 15%. Our total number is 2,227. 400, we have 400 pediatric patients. It's almost 1/3 of our patients are pediatric. It's not because we love children a lot. Yes, we do. But we are the only center that can solve this problem successfully. So if you look at this data, this is a comparison between pediatric and adult survival. So you see that even pediatric patient survival are better than adults because they are young, they have a good capacity to recover, and they are not sometimes not too very sick, but still you can think that even the difficult these cases like transplantation among small children can be that successful. But you know, pediatric, if you talk about pediatric patients, it is something that you can do like this, because pediatric cases, when we mention pediatric cases, it means less than 80 years, right? So what is the difference? A 70-year girl with her mother. Sometimes she might be bigger than her mother, you know. I am really talking for small babies, you know, less than 1 year. Look, This is a very, very important number. In my group of patients, less than 1 year number is 124. And the others, one between 1 and 80, 276. So let's compare them, because the very, very, imagine 4-month-old baby getting a transplant, like 4 or 5 kilo baby getting a transplant. It's very difficult. It's not only size, less. In this issue, size matters, but it's not only the size. It's not only place for placing a liver there. So the vessels, to sewing them to each other, to arrange it to work, very difficult. And as I mentioned the difficulty, yes, these very small children doing worse than the bigger ones. Because if you look our data, 1, 3, 5 to 10 year survival are significantly worse than the bigger ones. But how? 10 year survival is 71%. Look, 1 year, less than 1 year child, if they don't get transplanted, they die, and you give to 70% of them a chance for long time living. So this is a slide from 2 years ago that we are celebrating our 1000th transplantation in the OR with our team and friends. And the other thing is that we not only make transplantation, we also educate people. You see, from United States of America, Germany, and some neighboring countries, and also from other cities, other regions of Turkey, people are coming to us for short term or for long term to learn how to do also liver transplantation. So this is the business, and this is also the end of my speech. Thank you for listening to me, and please, if you have any questions, don't hesitate to ask anytime.
Good morning, ladies and gentlemen. I am Alper Murat Ulaşlı. I'm a physical medicine rehabilitation specialist working for Lokman Hekim University in Ankara, Turkey. Today, I would like to talk about regenerative treatment modalities for musculoskeletal diseases, which is nowadays a hot topic. Starting with PRP in the late 80s, there has been a paramount growing in the regenerative medicine field. Currently, the researchers are actively exploring the use of growth factors, genes, stem cells, exosomes, microRNAs, and biomaterials, alone or in combination, in order to enhance healing. The field of regenerative medicine is relatively new, but it's expanding rapidly. Also, the published papers in this field has a rapid increase, as you see here. Me and my colleagues also have some papers about this field in regenerative medicine. So the question is, why should we use, or do we need to use regenerative treatment modalities in our daily lives, in our daily practice? At the beginning, the regenerative treatment modalities started as an alternative or supportive treatment method for conventional treatments. But now, as we use injectable biologics in a wide spectrum of diseases, we are discussing the evidence to use or not, or in which stage of the disease we should use. Everybody experienced in orthopedics or physical medicine know that conventionally we use steroids and local anesthetics for treatment of joint and disease or tendon problems in the past. But the research showed us that although the steroids have strong anti-inflammatory effects, they are also harmful for living cells, I mean tendon cells, cartilage cells. The PDGF, which is platelet-derived growth factor, is shown here in this study to reverse, at least partially, this harmful effect. And what about we use the local anesthetics and steroids together? It's worse. They synergistically have deleterious effect here on tenocyte culture cells. So, are we in a dead end? No. Nowadays, we have numerous studies, new and ongoing ones, in regards to the effect of the platelet-rich plasma and bone marrow aspirate concentrate and adipose tissue-derived products in a wide spectrum of diseases, including lateral epicondylitis, rotator cuff tendinopathy, plantar fasciitis, Achilles tendinopathy, facet joint arthropathy, non-unions or fractures, osteochondral lesions, and osteoarthritis. But the indications are not limited with these problems. Here you can see the use of adipose tissue biological products, I mean microfragmented fat, nanofat, and stromal vascular fraction in a wide spectrum of diseases. In almost all studies, the pain of the patients is reduced and the function is improved. So we have many reasons to use biocellular therapy. There are various kinds of biocellular therapy in daily routine we use, starting with whole blood therapy, autologous conditions plasma, platelet-rich plasma, platelet-rich fibrin, and rich in growth factors, concentrated growth factors, bone marrow aspirate concentrate, adipose tissue autograft, including nanofat, microfat, and stromal vascular fraction, amniotic cell concentrate, umbilical cord derived stem cells, mesenchymal stem cells, exosomes, and nowadays human very small embryonic-like stem cells. The ones on this side are easily obtained without any further manipulation. We can obtain these biocellular products with minimal manipulation to complete regulatory issues. But on this side, again, nanofat and microfragmented fat can be obtained in completely interfering with regulations. But if you use enzyme to obtain stromal vascular fraction, you must obtain a permission from regulatory institutions. So in our daily routine, because they are cheap and they are easily obtained and prepared rapidly, we prefer to use the ones in the left column, stromal vascular fraction, which is mechanically prepared, and nanofat. The focus of regenerative medicine is human stem cells. There are various kinds of stem cells, adult stem cells, embryonic stem cells, and induced pluripotent stem cells, which won the Nobel Prize in 2012. The embryonic stem cells, the use of these cells are not allowed in most of countries. So the bone marrow-derived mesenchymal stem cells and adipose-derived mesenchymal stem cell are two sources we use mostly. Stem cells are classified into different cell types, starting with totipotent stem cells and going with pluripotent embryonic stem cells. These two are not allowed to use in clinical routine. But we can use multipotent stem cells, including mesenchymal stem cells, neural stem cells, and hematopoietic stem cells. This picture is from one of our ongoing studies. Mesenchymal stem cells are also called mesenchymal stromal cells, medicinal single cells. They have fibroblastic-like morphology. They have low immunogenicity. They have anti-inflammatory, anti-apoptotic, antifibrotic, and immunomodulatory effects. These cells are multipotent, which means they can self-replicate, proliferate, but also have potential to differentiate into different cell types, including osteocytes, chondrocytes, smooth muscles, and skeletal muscles, and tenocytes, and also adipocytes. But if you provide certain conditions for these cells, besides they differentiate to mesodermal lineage, including adipocytes, chondrocytes, and osteoblasts, they can also differentiate to hepatocyte, liver cells, pancreas cells, neurons, and skin cells too. So what happens if we inject mesenchymal stem cells into a joint? They secrete various kinds of exosomes, and they regulate cell differentiation, they release cytokines, they induce cartilage regeneration and suppress cartilage degeneration. They act like a drugstore and support the natural healing process of the home tissue. They have anabolic effects and anticatabolic effects and immune modulation effects. And what's the optimal source of these cells? It must be easy to get. It must reveal high quantity of cells with minimum morbidity. These cells should be multipotent and should proliferate to different cell groups, and it must be safe after implantation. So, bone marrow and adipose tissue are two common sources we use in daily routine. Starting with bone marrow derived biocellular products. Bone marrow includes mesenchymal stem cells, hematopoietic stem cells, but besides, the bone marrow includes very important cells too, like Muse cells, which act like embryonic stem cells in the organism. The pericytes, the other important cell, they can act like mesenchymal stem cells, and endothelial pregnant cells work in vasculogenesis of the tissue. The stem cells are resided in subchondral bone and perisinusoidal regions of the bone. If the patient is awake in my clinical routine, I usually perform my bone marrow aspiration using ultrasound guidance here. But also during a surgery, if the patient is under general anesthesia, you might not need a guidance. You can palpate or make a small cut and can see the bone you target. After filtration and activation, we can obtain two major kinds of bone marrow aspirate products. The one is bone marrow aspirate concentrate here. The other is bone marrow matrix, which has a 3D shape and can be used for special purposes. And we continue with adipose tissue derived biocellular products. The adipose tissue is an abundant source of mesenchymal stem cells, but not only mesenchymal stem cells. Besides mesenchymal stem cells, they include pericytes and endothelial progenitor cells, hematopoietic stem cells, and the others. These two cell lines are very important for tissue healing. For harvesting adipose tissue, mesenchymal stem cells from adipose tissue, we use local anesthetics. And in case we need ultrasound guidance, we check the thickness of the fat tissue. We target to aspirate. The adipose tissue may be processed to produce small portions for the purposes for performing a fat graft or lipotransfer. Here you can see stromal vascular fraction, including only cell lines. This is non-fat. It has size less than 1 millimeter, and these stromal cell aggregates have a size over 1 millimeter. The SVF contains adipose stromal cells, endothelial cells, pericytes, fibroblasts, monocytes, and adipose-derived mesenchymal stem cells. It's a heterogeneous cell population. After lipoaspiration and centrifugation, we obtain this 3-layer biocellular product. And we use special blades to microfragment the adipose tissue. And at the end of this processing, we can obtain 2 kinds of final product. The one is nanofat, the other is stromal vascular fraction. Both of them can be used for regenerative purposes. We use ultrasound guidance for most of the joints for regenerative injections, and also one can inject biocellular material blindly, for example, for knee joints. In summary, the use of biologics in musculoskeletal conditions can be summarized, but not limited to, joint and cartilage damage, osteochondral lesions and osteoarthritis, non-union fractures, avascular necrosis of the bone during surgery, shoulder osteoarthritis and rotator cuff tears, tendinopathies, viscogenic back pain, knee problems, meniscus tears, and hip problems. Thank you.
Турция – новая точка на карте мировой медицины. Ее расположение идеально. Она находится на стыке 3 континентов – Азии, Африки и Европы. Инновационное оборудование, квалифицированный персонал и доступные цены. Все это за последние 5 лет позволило Турции войти в 3 стран-лидеров по медицинскому туризму. Впереди только США и Германия. Самое тяжелое заболевание. Самые сложные операции. И своевременные вмешательства. Восстановление. И реабилитация. Продолжение рода. Красота и молодость. Весь спектр медицинских услуг вы получите в Турции. Доверьте нам самое ценное – ваше здоровье. Каждый заслуживает свое маленькое счастье, но не всем это удается. У 5% мужчин и женщин, у 48,5 миллионов пар диагностировано бесплодие. Эта проблема острым вопросом стоит в современном обществе. И выход есть – это экстракорпоральное оплодотворение. Только в Турции ежегодно проводится более 50 тысяч процедур при успешности около 65%. Почему люди со всего мира выбирают именно это место? Благодаря своим инновациям Турция предлагает новые методики вспомогательной репродуктивной технологии, которые помогают повысить шансы на удачное оплодотворение. Даже у женщин со сниженным авариальным резервом. Индивидуальный подход и подбор протокола для каждой пары с использованием прогрессивных методов ЭКО. В случае истощения авариального резерва или наличия мужского фактора бесплодия также существует возможность донорства. В программе донорства участвуют только сертифицированные доноры, проверенные на наличие инфекций, генетических и психологических заболеваний. В случае необходимости проводится предимплантационная генетическая диагностика, позволяющая исключить генетические нарушения эмбрионов и достигнуть главной цели – рождения здорового малыша в семье. Ведь каждый заслуживает свое маленькое счастье. И никаких «но». Успех борьбы с онкологическими заболеваниями много в чем зависит от ранней диагностики. Турция – страна, в которой за последние 10 лет уровень медицины вырос в несколько раз, а онкология стала приоритетом в лечении. Цены более доступные, чем в США и Европе. Турецкие нейрохирурги входят в первую пятерку команд в мире по использованию технологии гамма-ножа. Она позволяет убивать опухолевые клетки без оперативного вмешательства путем высокоточного радиационного облучения, существенно сокращает период реабилитации и предотвращает осложнения. Также в Турции практикуют выведение пациента из анестезии прямо во время операции на мозге. Ему задают вопросы, тем самым проверяя работу речевого аппарата, и проводят МРТ, чтобы убедиться, опухоль полностью удалена. Для опухолей простаты и женских внутренних половых органов радиоактивные лучи доставляются по специальным пластиковым трубкам непосредственно в опухоль. Эта технология позволяет сократить количество сеансов облучения и предотвращает образование ожогов. Рак – это диагноз, а не приговор. Травмы опорно-двигательного аппарата, головного и спинного мозга, параличи и детский церебральный паралич. Вот неполный список диагнозов, когда реабилитация так же важна и необходима, как и основное лечение. Инновационное оборудование, квалифицированный персонал и индивидуальный подход. Всевозможные вспомогательные процедуры и дополнительное лечение. Физические нагрузки для окончательного выздоровления и профилактики. Но главным преимуществом турецкой восстановительной медицины является роботизированная реабилитация. Благодаря роботу-тренажеру человек, который долгое время был прикован к постели, может ощутить вкус ходьбы и даже почувствовать спортивный азарт с помощью компьютерной игры симуляции. Параллельно с разработкой конечностей пациентов учат, как использовать восстановленные навыки движений в быту. Доверьте нам самое ценное – свое здоровье. И давайте шаг за шагом двигаться вперед. Уровень трансплантологии в Турции один из самых высоких в мире. Ежегодно здесь проводят более 5000 операций с пересадки органов. Это больше, чем в любой стране Евросоюза. Среди лидеров – трансплантация печени, почек и костного мозга. Как взрослым, так и детям. Трансплантация печени и почек в Турции возможна только от доноров-родственников, хотя бы 4-го колена. Для пересадки костного мозга сначала ищут доноров-родственников. Если таких нет, можно обращаться в донорские банки. Для пересадки роговицы пациенты могут воспользоваться услугами Национального банка доноров Турции.
I am interested in especially bone marrow transplantation in children. We can do...
Трансплантация стволовых клеток – еще одно направление, которое быстро развивается в Турции. Терапия стволовыми клетками показывает хорошие результаты при таких серьезных заболеваниях, как детский церебральный паралич, травмы спинного мозга, цирроз печени и некоторых аутоиммунных заболеваниях. Для многих пациентов это, если не шанс на выздоровление, хотя бы на улучшение качества жизни.
Doctors, I have been working on stem cell for the last 20 years, just stem cells. Today I would like to inform...
Медицинский туризм в Турции. Доверьте нам самое ценное – ваше здоровье.
The art of medicine is the heritage of Anatolia. You are in Turkey, the place where the first hospital of the world was founded and Hippocrates was born and grew up. In these lands, we treated the diseases with water, precious plants, and music. Our thousands of years of medical tradition reached a new level today with the advanced technology. But hospitality of Turkey and its air, useful for both soul and body, is still the same. Turkey attracts everybody by its nature, history, dynamic social life, as well as the best and most effective treatment possibilities since long time. With its high-standard hospitals and doctors known around the world, Turkey maintains its specialty of being the center of health of the region since long time. Because Turkey is at the intersection points of its continents. It is located at the center of Europe, Balkans, Russian, Middle East, and North Africa. Approximately 1 billion people can arrive at Turkey only with a few hours' flight. Turkish Airlines carries millions of people from 120 countries and 290 cities to Turkey by direct flights. There is a reason why so many people prefer Turkey. Because Turkey offers the newest technology treatment systems at the same time with the world. With its competitive price policy, it is among first choices of those who are looking for the top quality service with optimum prices. Turkey provides comfort with its high-standard hospitals during healing process, with its hospitals having Center of Excellence Awards and Joint Commission accreditation certificates. It maintains its privileged place in the region. An experienced team with 724 specialist services and air ambulances works for satisfaction of the guests. Experienced Turkish doctors who break grounds all around the world continues to control their patients after treatment. Thus, Turkey takes place on the top 3 in the world health tourism destinations. Turkey accommodates patients from 144 countries every year in the risky treatments and operations required high technology. It uses robotic surgery, Marrow, organ, and stem cell transplantations are performed by awarded doctors through the latest technology. With innovative treatment systems such as inorganic organ production and transplantation, life-saving results are achieved. There is a progressive vision behind this success. Mustafa Kemal Atatürk, the founder of modern Republic of Turkey, started this vision by saying, "Entrust me to Turkish doctors." Today, Recep Tayyip Erdogan, President of the Republic, is still treated by Turkish doctors. Since the early years of the Republic, young doctors have completed their postgraduate education abroad. Turkish health sector has made a big progress with an investment of $30 billion in 15 promising successes in the treatment of common cancer and cardiovascular diseases. A complete healing is achieved in a short time by non-surgical treatments of the brain tumors. Children needing treatment in different branches such as blood diseases, marrow transplantation, heart surgery, brain tumors, etc. are also achieving health again in Turkey, because the best treatment methods are applied with a smiling and kindly approach. Services allowing the children to have a pleasant time facilitate treatment processes. Children, our most precious existences, are deserving of this special attention. Also, there are many treatment alternatives for those who want to have children in Turkey. Couples are enjoying having children and growing their family with infertility treatment, advanced genetics applications, and in vitro fertilization methods. Turkey is where the civilizations was born and continue. With its active city life, untouched nature, and majestic history, Turkey transforms your treatment process into a comfortable and pleasant holiday. .375 member organizations, which adopted ethical principles of Turkish Healthcare and Travel Council, work for happiness of the guests. We are at the intersection point of hearts and continents. Hope to see you soon. Right choice for your life. Turkey. Healing generations for centuries.